Excuse me, everyone. Welcome back, everyone. I hope you all had a chance to grab some food and some good conversation. If everyone could try to keep it to a dull roar, we would like to reconvene. Thank you. We have a few special presentations coming up. First, I want to welcome our live stream audience. We are going to have the rest of this afternoon available online for folks joining us remotely. So thanks for tuning in. And thanks to those of you here as well. We are now going to have a special video presentation here from several of our Founders Council members, some who are here with us and some who weren't able to join us. And then we're going to go into a really exciting panel. We've got our esteemed panelists up here with us, and I will let our moderator introduce them when we get started, but really looking ahead to forging a path to affordable, quality healthcare for all Americans. And first, we will start with our special video.
Someone told me one time that you either build up people or you tear them down. I'm a nurse and a clinical psychologist, and I just forcefully, with all of me, believe that we build people up.
I'm a member of the United States of Care Founders Council because I believe we must do everything possible to ensure that everyone has access to affordable, high-quality care.
I believe that the voices of those directly affected by healthcare should be the ones leading the conversation.
The reason I joined United States of Care is because healthcare is the reason that I got into politics. And the reason for that is because, like so many other people who care a lot about this issue, I had many close friends and family in my life who've had scary, life-threatening health experiences, health conditions.
At the United States of Care, the mission is clearly to create an American healthcare system where everyone has truly affordable, accessible, and quality care.
We spend too much money paying for procedures rather than looking for outcomes, and we end up incurring a lot of costs.
So how did we get to where we are? Well, it kind of starts with our history. We created a history and a culture of fragmentation that really has put the person who matters the most, the patient, not in the right position.
I think the most important thing we can accomplish that will move us toward the goal is learning to create an economic system that moves away from fee-for-service medicine and toward value.
Access to care is too often determined by race or income.
We've made it about other people, not the person that's actually looking for care.
It's infuriating, it's enraging, and in the richest country on earth, it's completely unnecessary.
We need to start talking about healthcare in terms that really fit everybody, whether they're lower income, middle income, or upper income. They should all feel like the solutions we're focused on work for them.
We have to work toward coordinated care where everyone in the ecosystem of health is involved.
We need to listen to patients, to people with disabilities, people with chronic illnesses, and caregivers.
A lot of our solutions will require courage. They require leadership, us to be brave and to be bold and not be afraid of what our colleagues or peers think, but to do something that's truly outstanding.
Healthcare isn't just what happens at the doctor, it's what happens in the community. And the social determinants of health will have an increasing role and increasing importance in this discussion.
Healthcare is complex. There is no silver bullet. There is no easy fix, but we cannot let that deter us. We need to roll up our sleeves and work every day to make progress towards our goals.
Truly affordable, accessible, and quality care for all.
Okay, I guess I'm on. I am Julie Rovner with the Chief Washington Correspondent at Kaiser Health News. We actually live upstairs here. And I want to thank everyone for being here. And I want to thank this esteemed panel, who I will now introduce. Here to my right is Steve Beshear. He's the former Democratic governor of Kentucky. During his tenure, he launched one of the most successful state-based exchanges and expanded Medicaid, providing coverage to roughly 500,000 Kentuckians and seeing the state's uninsured rate plummet from 20%, one of the highest in the nation, to 7.5%, one of the lowest. To his right, to his right is Senator Bill Frist, former heart and lung transplant surgeon, so a provider, Republican senator from Tennessee, and Senate Majority Leader, among many other accomplishments. And finally is Sandra Hernandez. She's president and CEO of the California Healthcare Foundation. She's the former public health director for San Francisco and one of the founders of the groundbreaking Healthy San Francisco program, which predated the ACA. So I'm going to chat with these folks for about a half an hour, and then we will turn it over to you for your questions. I will remind you when we get there, but please tell us who you are, and please make your question a question. First, I would like to ask each of you this question. What would the U.S. look like with everyone able to afford quality health care? This, if you look around the world, you can see this can be done in a myriad of ways. If you could wave a wand and make it happen, what would your utopian health care system look like, Governor?
Well, being on the board of the United States of Care, I would say it would look like the implementation of all the principles that all of you all saw this morning. But you know, as a former governor, I'm not much of a magic wand person because it doesn't work in terms of getting anything done. I think that's one of our problems is that so many of us get wrapped around the axle with ideology and the magic wand solution that we lose sight of the practicalities and the pragmatic things that we need to do to try to move the ball forward. And that's what governors do, at least the successful governors do. You know, and when the ACA came along, you know, here I was in Kentucky where President Obama had a 30% approval rating. That was going to be exciting for me. But I decided to implement the ACA and expand Medicaid because to me it was the right thing to do. And I always say I had a two-part decision-making process. I tried to figure out what the right thing to do was, and then I tried to figure out how to do it and survive. And so we decided to do it. We took every dollar the feds would give us to plan. And I figured out that the word Obamacare was a curse word in Kentucky, so I changed the name to Connect. And I still remember the fellow, you know, trying to sign up at the state fair, and I was listening, and he ended up saying, "Oh man, this is great. This is a lot better than that Obamacare." But you know, he signed up. And so we implemented that, and what we see today, because of, I think, the practical ways that we did it, is that Kentuckians generally still don't like the phrase Obamacare, but they sure don't want anybody taking their health care away from them. And, you know, so I would come back to, you know, it's time for us to kind of put aside our magic wands. And, I mean, the senator knows very well what I'm talking about because he's tried to herd the cats up in the Senate for years. And you've got to find some common ground, and then, like we're trying to do with this organization, and let that bubble up and become kind of the genesis of where we go from here.
Senator, you've seen this obviously as a provider, as a legislator. Now you're working in the private sector. I mean, what would the goal be? What would it look like when we achieve a state of a functional healthcare system with everyone covered? You know, that it's I think it's a fundamental question to ask, and it's a great one to start with. And if everybody had better health care, people would be healthier, greater well-being, dreams would come true, people would live longer, more fulfilling lives. But if it's just affordable health care for everybody, the world wouldn't change very much. And I say that, I'm a surgeon, and I like to think taking people's hearts out, moving them around makes a big, big difference. And they do live longer, and they live happier,
and they see grandchildren grow up, and it's a great technology that is now pretty routine. But, and this is what was good about this morning, to have affordable health care for everybody is just not enough. And it comes back to the basics that we all know, that if we fix all that, that's maybe 15, maybe 20% of happiness, well-being, health, not health care, health, and well-being. And so as people throw in the word social determinants, and we talk about food and housing and where people live and culture, which we'll talk about later. So the way you phrase your question, not very much. And until you link the 15% impact of our healthcare system and Obamacare and universal insurance and access and affordability to the 40% of behavior and the 10% of environment and climate, and that gets you in a lot of areas, until we link all of that, it's not going to change the world as much as we would like to think. So the social determinants, which we'll come to later, have to be linked to it inextricably, which may not apply to affordability for everybody. It's more than that.
Well, thank you for the question. Nice to be here. I'm not going to take the wand either. But I will say this, and maybe this comes from living in California, where we can see our way potentially to getting everybody covered. I do think we as a country can get everybody covered. And, you know, with a combination of leadership in state houses, a ton of innovation, a secretary who's interested in moving into different forms of payment, all the innovations we've seen in different states. So I actually think we will get to universal and should get to universal. And then it's worth noting, as the senator alluded to, what we don't spend in social services, if we compare ourselves to any of these European countries that cover everybody and that have much, much better health outcomes and are much healthier than our populations are, we really need to think about where those dollars get invested in prevention, in population health, in all the things that we know contribute to the things we see that are then expensive to care for on the back end. So I think, though, and this was the principle behind the ACA, which was you got to get everybody covered first and then go to affordability. And that affordability should be in part, where do we reinvest that on the prevention side and on social determinants of health?
So I want to come back at that, because the principle, you're right. When they were doing the ACA, the idea was we can't take care of cost and structure and everything else in the system until we get everybody covered. A lot of the pushback was, no, we have to figure out how to get control of costs before we can cover everybody, which we're now at sort of another tipping point. Do we have to get costs under control before we cover everybody else, or do we need to cover everybody else before we get costs under control?
Well, let me just say this, and it was one of the tenets I think Andy spoke to this morning, and that is if you look at the long game, there is no investment that we make in prevention that we get an ROI the next year, or that the CBO is going to be able to mark up the next year. And so and by the way, we eviscerated most of the prevention and community-oriented services that were built into the ACA. We have to have a long game if we're going to benefit from that prevention. And we also need to start much earlier. We need to really think about, you know, prenatal care all the way through, home visits, so I think we've been impatient with the principles in ACA that would have brought us much more in relationship to prevention and to some of the community services that were originally envisioned in part of the ACA.
Senator, do we have to do something about costs before we can cover any more people?
No, I think it was a huge mistake for our country to go in a direction of just access. I'm for universal access, affordable universal access. But, and people will come back and say, yes, but we had a lot of cost provisions in there. But if you really step back from a legislative standpoint of having to watch the way things were done, I think it was a huge mistake, just going with access itself. And the pushback today from people where I live, where the governor lives, is just that. You know, the access is okay, but if I still can't afford it, I don't have the access itself. So that was a mistake, and I think most people will recognize that. So it has to be done in a dual way. We have to do everything we can for affordability, but neither is going to work if it's going to be one versus the other. And we may be swinging too far the other way right now as well, but it's got to be a dual approach. Every conversation has to be a dual approach. And when you're talking to real people, patients at the dinner table, which is the focus of very much of what we're doing, they will tell you just the same thing.
Yeah, you have, out there today, the folks on expanded Medicaid, they are, in my state at least, relatively happy in that they've got coverage for the first time. And the emphasis on wellness and prevention, has really, while we all know you can't really measure this thing for 20 years probably in terms of better health, you can look at some short-term determinants like screenings. And our screenings went through the roof in Kentucky. Every kind of cancer screening, cholesterol, diabetes, blood pressure, whatever, it went through the roof. And hopefully what that means, obviously, is that you find out about the disease or condition early, you teach people how to manage it, and therefore in the long run you're going to save some money, or at least keep the cost curve from going up as rapidly as it's going up. But you've got another set of people out here who some who are getting subsidies that, with the way the premiums have gone up, it's not sufficient for them to afford anything. And then the folks that are just above qualifying for subsidies are getting killed. And there's a variety of reasons for that, I'm sure, but the fact is they're looking around going, oh my gosh, I want this too. And it's kind of reverberating back down, and people are saying, well, they're getting it down here at the Medicaid level, and how come I can't even afford anything? So we've got to address this cost thing, I think, as well as the access.
You may be sort of getting to my next question, which is, I get that you're not all wand people, but I think the object of this panel is to talk about a path to sort of get us to the goals. What would you do first if you could sort of do one thing that would sort of start a glide path to?
I think there's one idea out here that's being utilized in a number of places, but we need to utilize it a lot more, and that's paying for quality as opposed to quantity. The fee-for-service model would break us all if we kept to that. I took our Medicaid program even before I expanded Medicaid, and I actually did it for budget reasons. I became governor at the end of 2007, and guess what hit about that time? The Great Recession. And our revenues actually went backward. I mean, we had less money the next year to spend than we were currently spending. So we had to do something, and part of what I did, as opposed to cutting benefits, is that we took about 80% of our Medicaid system to managed care in an attempt to try to, use capitation and all of these things to start controlling cost. And I'm sure there's myriad ways of doing it, but to me, us beginning to pay for quality as opposed to quantity is just a must.
Senator First.
I agree. We saw the pendulum switch with this administration away from value-based care with the initial secretary for HHS, and then now swinging way back towards it, which is really fascinating to me.
And it's not so much if you're a provider.
Yeah, no, exactly right.
Bundled things.
That's what that was. I would have cared when I was doing the heart surgery back then. But so the value-based care, I think, is the direction to go. Where we are in this climate, where we have a president in particular who's not focused on health care, it's probably a good thing that he's not. but because we have some good people working to figure things out without being slapped down. But I think from a practical standpoint, value-based care is good, so you get a little bit of bundling in and you kind of move to the directions you can at the policy level. The states will be, as we talked about this morning, have the opportunity to innovate a lot more. And in the social determinants area, putting what really is value to determine outcomes, and not just paying for things and not just saying, here's a doctor, because it's so much more than that. So the innovation at the state-based and local level of incorporating social determinants into the acute delivery and preventive care and the like. So that's one thing that I'm encouraged about. Number two is what I would do is start, and what I do in my own mind is start where you can pull, and this is politics in me, where you can pull Republicans and Democrats together around a common message they both care about, both have buy-in outside of the political realm of partisanship. And one area is end of life. And we saw it in hospice 30 years ago. We have so much to learn from other countries, which, as Andy talked about today, other countries are doing great things. The hospice arena, which had its origins pretty much in Europe and in England 100 years ago, Took us 70 years to learn. We learned it. It was implemented here. It's executed on. Very successful. And that's really the last 2 weeks. It should be the last 40 days, the last 2 weeks of life. But again, there's a great common ground in the palliative healthcare world, end of life. We're going to all be there. All 350 million people of us are going to be there. We have more than one disease. It's going to go over a long period of time. Use that as a model to put value-based care, wrap teams around those people, get the cost down, because it doesn't have to be expensive if it's chaotic fee-for-service. The cost comes down if you wrap a team in a value-based system. And build out from that model. So you did hospice, you do palliative health care, you can do sort of more senior type chronic disease care, but start bite-sized, bring people together, build the models out. Just close with that. For example, palliative health care, to really do it right, takes coming to CMS and building a new financial model that's not strict for fee-for-service, but in the Medicare Advantage world will allow you to put that model together. Once the model works for palliative health care, chronic disease, you can expand it out through the system.
You know, we've learned a lot in California about how to make the ACA work. And so, you know, premiums on covered California have been in single digits really throughout the time that California implemented the ACA. And so I think it's just worth highlighting what allowed that to happen. What are the conditions that in California have allowed premiums to grow at a much slower rate than really they have in other exchanges elsewhere in the country? Two of those that are really important, and that is outreach, and spending the money that it takes to go during open enrollment and have people who are eligible know about what's available and getting that coverage. And I think that and telling the message about if you choose not to be covered, you do put yourself financially and your family financially at risk, and really kind of drilling that down. That has really created a culture of coverage in California. People now understand what open enrollment means. And even as the feds have dramatically reduced outreach dollars, something to the tune of $10 million, Covered California is spending upwards of $100 million doing direct outreach to try to create that ongoing sense of coverage, which then allows you to have a much larger risk pool, which then does allow you to have some negotiating power with plans. And so I think it's really, you know, reinsurance was talked about this morning, and there are certainly, you know, all the nicks that have come at ACA. But I think mostly what we've learned is that you can keep premiums down if you can keep people in to coverage. And, you know, people churn through that appropriately so. They get employed, you know, they get a new job, they get employer-based coverage. That's great. They've learned about coverage. So that's one. And the second thing I would say, I should say I'm on the board of Covered California, so I'll disclose that. But the second thing I would say is that as an active purchaser, working with plans to sort of begin to look at things like palliative care and what are the outcomes we're trying to reach in reducing disparities and the like, and working in partnership between the exchanges and the plans, 11 plans in California. So I would say that affordability does come with getting everybody in, which was a tenet of ACA. And so again, I'm assuming we're not going to get some big new health reform, you know, we're going to have a split Congress and the like. But I think we should learn from those exchanges that have been quite viable and that have kept rates down. Now, as you know, there was a single payer bill was introduced in California. It promptly got tabled in committee. But what it generated was a select committee to begin to look at, okay, what subsidies do you use at 400%? And really, how do you sort of thinking about softening those bridges that were talked about earlier today?
People who are getting hammered.
Exactly, people who are getting hammered. So, you know, that will be on us to look at. States potentially deciding themselves to do some version of requirement for having coverage is another thing that we're now seeing. California will surely look at that. So my whole point here is that affordability was built into the ACA if all the provisions were still at play. And they are not all quite still at play.
Mm-hmm. All right, well,
go
ahead.
There's one other issue after the senator mentioned end of life. It's a bigger bite, and it probably would have to come after a smaller bite like he's talking about, but it's the whole opioid crisis situation. You know, you talk about an issue that seems to be rather bipartisan in terms of people buying into doing something about it. I mean, you still have people arguing about a little bit about, you know, they don't deserve help because they've made a bad decision. But I think for the most part, we're coming to that point of everybody saying this is a disease and we really have to do something about it. And of course, it's no respecter of persons. it affects the wealthiest as well as the poorest families. So, something around tackling that issue might well bring some bipartisan effort and a wraparound kind of approach to the social determinants, because the treatment and getting people weaned off of drugs and then turning them right back out, and they don't have proper housing, they don't have enough to eat, they're in the same environment. We've got that vicious cycle going, and so that would be another area that we might be able to do something.
Jay, could I just both Senator and Governor both mentioned palliative care. Hartford Foundation, California Healthcare Foundation did a big survey. This falls into the spirit of, if you ask people what they want, you actually hear what they want. And what we heard overwhelmingly was a desire for palliative care services, if you unpack it and describe it what it is. And so I think this is one of those things where we're very much behind where our families and our communities and patients really want to be as it relates to accessing palliative care, team-based care to be able to take care of end-of-life issues and the like. And similarly, we surveyed clinicians who likewise said we weren't given the tools to be able to talk about palliative care or hospice care. So I think we have a lot of work to do in this country. It's something that is really quite driven by patient interest and family interest, and we don't yet have it packaged. We haven't done the training programs for it. There's just a lot of opportunity, as the Senator and Governor mentioned, on palliative care, I think, in the country.
I think one of the big issues is that we don't really have a healthcare system. Most other countries have this far more formalized and regularized. We have an extremely ad hoc system. And Senator, you kind of alluded to this already, but it was already my next question. Bipartisanship, when I first started covering healthcare in the 1980s, was the norm. Actually, the partisan fights about healthcare were the exception. It was mostly Democrats and Republicans working together. That has obviously diverged. We've now seen the term primary become a verb. So, Democrats and Republicans tend to, even if they want to work together, tend to, if not retreat to their corners, get dragged back to their corners. How can you, is there a way to overcome that in something as big and as clearly important to everybody, to Democrats and Republicans, as the state of the healthcare system?
I think so. I think obviously the U.S. of care, I think as we go forward, it's very important for us to be sort of nonpartisan, bipartisan, encourage the discussion back and forth. The partisanship is going to pass, even though the red got redder and the blue got bluer. So I keep saying this, and people, yeah, that's right. The polling data shows that the things were aggravated. But there's some good signs there. In the midterm elections, as was implied today, was the greatest turnout in the midterm elections in the last 60 years. People care. People care. Again, I know they got more polarized because that's the next bullet down, but people care. And as people care, the health care issue, for the first time, I went for months and months debating and talking, saying health care is not going to be a big issue here. It never is. And it never is historically until we have it today. As we hear talk about patients and families and dinner table and engagement, which I agree with 100%, and then we have this other thing that people politically begin to care, that gives a huge opportunity today to capture people around health and around health care and have it bubble up. It's not going to start in the Capitol right now. Tom Dash, when I was majority leader, Tom Dash was Democratic leader, I was Republican leader. We had debates. We spent time together at night and that sort of thing. So that's changed a little bit now. But now here, 20 years later, 15 years, how old are we? 15 years later, 18 years later, Tom Daschle and I have written 25 articles together. Tom Daschle, Bill Frist in Politico, The Hill, New York Times, LA Times, Washington Post. We've written 5 bipartisan op-eds in the last 8 months. We've written, I think, 27 in the last 6 years. I think there's going to need to be more of that, where U.S. of Care, and there are other groups out, the Bipartisan Policy Center, which is sort of also active here. Kaiser, you up here, where you have a voice that it doesn't have the partisan filter, gives us a great opportunity. We have greater turnout, greater interest in the midterm election ever. Healthcare, the number one issue. The health literacy, which is what the individual engagement California does well, our federal government is running from, which is something to learn from. I'm optimistic underneath. I'm literally optimistic underneath.
It's going to have to start at the local level, though. I mean, we need leadership like he and Senator Daschle are doing, and that is so important, just to be seen with your names on the same thing. I mean, these days, isn't that amazing that we get all excited because, a Democrat and a Republican actually co-author something? But the more this can bubble up from the state and local level, I think in the long term, that'll change the way people act up here of necessity. I think some folks up here got their eyes opened a little bit over the last 2 or 3 years, and it was on health care because we made it such a partisan issue. And then, they end up passing or wanting to vote on things that was going to take coverage away from 20 million people. And so all at once, when they went home, people were paying attention. I mean, folks never pay much attention to what goes on up here, but they started paying attention because, oh my God, you're going to take my health care away. And I think it was both Republicans and Democrats coming to those town hall meetings and saying, wait a minute, I don't know what you call it or what you want to do, but for God's sakes, don't take my health care away. A very simple kind of thing, but it got everybody's attention. And I think the more that on a local level, like U.S. of Care is doing, innovating, getting states to come up with innovative ideas and everything, that will bubble up. And I think the Senator's right. It's not going to happen up here. It's going to have to come from kind of the outside and from the bottom up. But the more that goes on, I think eventually healthcare is going to, I think, move back more toward a nonpartisan issue, and we'll be able to get some things done.
In California, you've got the Democrats by themselves who are completely divided.
Bluer than blue.
Yeah.
I mean,
first for the blue versus the blue, though.
So first, it's worth noting, we did the ACA during a Republican governor. Schwarzenegger really put the team together that did that. So it was a Republican governor working with a largely Democratic legislature. So just to note, that's how we got started, and I think worth keeping that in mind. There will be all kinds of who's left of whom in California and how far do you go and how quickly do you go. I think it will raise a conversation quite quickly about how do you think about recession-proofing a Medi-Cal program that serves 1 out of every 3 people in the state of California. When we talk about Cover California being very successful, there's only 1.5 million people in that. There's 13 million people in the Medicaid program in California. And so I think there is going to need to be that conversation, which I think that the legislature will want to have and will have. The advocates will have their say. We have a robust community input, community engagement. We have amazing health advocates. The unions will have a lot to say in California, obviously, and will continue to drive that conversation. I do want to say this morning it was mentioned how important the Republican governors were in protecting the ACA. And it's worth noting that California Healthcare Foundations recognized how important governors were outside of California who expanded Medicaid to California's Medicaid program. And so in that regard, really tried to share the data and evidence, doing the math, helping people really understand what are the economic impacts of expanding Medicaid, or if you don't.
Exactly.
And that was really important to governors who were on the fence and trying to decide what to do. We had the ability to commission that research, to do the data, to sort of shed light, both on what we had done in California but elsewhere. And I think we have a responsibility as a big state with a big Medicaid program to be able to do that, to be able to help the conversations that's going on in other states.
When I got ready to implement expanded Medicaid, I knew that the argument was going to be it's going to bankrupt us. We can't afford to do this. And so I brought in PricewaterhouseCoopers and asked them to do a study. What do you think? Make projections of what this is going to do to us and for us. And they came back in about 6 months and looked at me and said, Governor, you can't afford not to do this because it's going to create 17,000 new jobs over the next 8 years. It's going to infuse about $15 billion into your economy that you haven't had before, and it's going to have a positive impact on your budget. Well, that was pretty good. I like that. And so I went on and expanded. But then a year later, I brought in Deloitte Consulting and said, okay, now we've got a year's actual numbers. And I want you to take the PwC report and take the actual numbers and tell me where we are and how it's going. They came back in and said, well, PwC was wrong. They weren't optimistic enough. Because, they told you were going to create 17,000 new jobs over the next 8 years. You've created 12,000 new jobs the first year of this. And instead of, $15 billion, it's going to be $30 billion infused into your economies. But those are the kinds of things. When the NGA gets together, the National Governors Association, we have governors-only luncheons, and it's amazing, folks. We actually talk to each other, regardless of party. We sit around, we talk, and I had several Republican governors say, would you send me those reports? I mean, this is the kind of information we need to show that this is not just I'm a do-gooder. This is going to really benefit our economy, and overall, it'll move our state along.
So, Senator, you already brought up social determinants of health. I want to circle back to that, and sort of in the vein of what Governor Beshear was talking about, we've gotten to the point where people don't believe research anymore. I mean, how do you sort of educate policymakers, the business community, patients, in why, as you said at the beginning, access to medical care is not the be-all and end-all of health? I mean, how do we sort of make that jump as a society to looking at the bigger picture and calling that health care rather than just what happens in a doctor's office or in a hospital?
Yeah. There are organizations like the Robert Wood Johnson Foundation who made a major shift about 3 years ago, recognized early on that the government's not going to be the source of the information. And in this current environment that maybe it's social media, but where President Trump and the fake news and all, the distrust of everything, institutions, Congress, Wall Street, everything, I mean, really comes back to how do you engage today? If the thematic that healthcare is important, being a surgeon's important, the hospitals are important, but the behavior and the interpretation, what's going to actually affect behavior, it's no longer Bill Frist in a white coat, transplant surgeon coming in and saying, you need a heart transplant, we're going to do it, this is what you need to do. That doesn't work. The behavior end of it, and this is, again, I'm a little bit maybe too hopeful, is going to be influenced the peer-to-peer. And the peer-to-peer is going to be engaging peers, or it could be through social media, where people do have 20 friends and what they're thinking in terms of behavior. Smoking is a huge issue in Nashville, Tennessee. Nashville is probably one of the top 3 hottest cities in terms of attracting young people, new restaurants, creative people. Unemployment's low, taxes are low. Everybody moved to Nashville. But our population health, not healthcare, is poor compared to Charlotte or Austin or Cincinnati or Raleigh-Durham or Fort Worth or Dallas, cities that we're competing for. So then all of a sudden you get this local competition in it. Well, why do more people smoke here? Why do we have less parks, fewer sidewalks? Why is our obesity rate higher? Why do we eat more Hattie B hot fried chicken, which is why a lot of people come? But the why of that. And that sort of answer is not decided in Washington, D.C., and it's not decided by policymakers or where we think the solutions are. It's decided by local communities and groups and discussions. The old knitting clubs in Appalachia, sort of where we're from, where a group of people come and, once a week just knit together and they talk, and then all of a sudden that becomes the talk of the community of 3,000. Social media gives us that. Now we have everything that's going on with social media and the problems there, but again, we have a tool today that can accomplish what Washington and even governors are not going to be able to solve, to marry this concept of the 20% of impact of health is what we mainly are talking about, but the 40% is behavior and whether we wear our seatbelts and whether we smoke and what we eat and how we live and where we work and play and the like. And that's going to be really coming back to the engagement, whether it's formal engagement or health literacy or just where you get your information from. We have to inject there.
So go around policymakers and just go straight to the public?
Yes. Yeah. Well, I think the fake news thing bothers me a lot, and you introduced it. The vaccination now, there's a huge around the world, in France right now, in Italy, in Los Angeles, where people are not getting vaccinated. And that's a basic health literacy. It started with science, true fake science with autism, and that one paper 20 years ago that was disproven 12 years later. But from that, there's a huge distrust of science today, of good science. And if ultimately we're measuring outcomes based on science and scientific principles, if you distrust the basic science. So that's a huge issue, the sort of anti-vax movement, which represents the anti-science movement, that I think leadership does have to stand up and support over time.
Well, you guys answer. You guys can be ready with your questions. There are microphones on each side. Social determinants of health?
I agree with it. No, you know, it's a huge issue, and when you start thinking about how you're going to address housing and hunger and all of these things that come together or smoking or wearing your seatbelt, it's a big issue, and I'm glad that I think in Minnesota. And in California and some places where those discussions are going on, my guess is that they're going to lead the way and not Kentucky in that area, because we're still struggling just, to make sure we have our health system in place and trying to figure out a way to attack the opioid crisis, which is destroying a lot of lives.
At the federal, because the state level is important, but at the federal level, I got to put it on the table because I kind of been saying the federal level doesn't have solutions. Things like in Medicare right now, in Medicaid, the importance of food, which is basic. What we put in our bodies in terms of the healing after surgery, and if we send people out after 2 days instead of 4 days and they're living by themselves and fast food is there in their area of gangs, all that's the social determinants, but they bounce right back in the hospital. And so the fact that for the first time, in really the last 24 months, especially Medicare and Medicaid are beginning to think about and open up, especially to Medicare Advantage, reimbursement for food. In Medicaid, in the private sector, I invest to help put together a company that is one of the largest, it's like Meals on Wheels, but it's in 25 states and 35,000 meals a day to the Medicaid population, good, healthy food. So there are ways both in the private sector and in the public sector to begin some reimbursement for things that determine outcomes like food, and that is being included in our Medicare legislation or proposals today.
Who's got a question?
We answered it all.
Nope, Sarah has a question. Wait for a microphone. Yes, so our streaming audience can hear you, and please tell us who you are.
Hi, Sarah Dash, again with the Alliance for Health Policy. Thank you all so much for the panel. And Senator, this question is for you, but I would certainly love to hear what everyone thinks. When we talk about the social determinants of health, the institution of the Congress and to some extent the agencies is kind of divided into like the healthcare financing, the finance and ways and means, and then the sort of public health committees, and a lot of the things you talked about, Meals on Wheels, are dealt with in the appropriations. And I just wonder if you have any insights or thoughts as to how the institution itself might need to evolve and kind of work together a little bit better to address some of these concerns.
Yeah, it's a great point. As everybody knows, in the Senate there are 2 health committees, and then the boundaries are sort of artificial, but they're pretty discreet that you have to operate by. And then you have to pull those committees together. There's competition between the committees. Yeah, exactly. Yeah, exactly. And then there are 3 in the House. So it's a great question. I wouldn't bet that's going to change very much until we build this sort of groundswell. I will say that the opportunity outside of that to push the social determinants, and that very quickly takes you to the co-equal branch of government, and that is the executive branch. And again, everybody has different opinions of what's going on all over government itself. Just personally, having worked with really 3 presidents in some shape or form, The people in HHS now, I feel really good about the approach, both the public persona, what people see, but also what they're working on. And they're thinking social determinants. They're thinking how you do it through not necessarily legislation, but through regulation. So I think if I had to say, let's all get involved and look and talk and discuss and impact government, I have a lot. I think the leverage and impact will be much greater at the CMS area and in the expanded area where people can listen. You can go in, you can put science on the table. You know, private companies like many that I have will take data in and say, this is the data, this is the real world experience. It's not sort of Harvard, sort of Ivy League sort of stuff going on. And that's where I think a lot of the action is today. But I think your point's a good one. We need to think about how should the institutions within the Senate and the House change over time. I don't think they will very much now, but how should they?
Either of you want to add something to that? No.
He's the one that served there.
Next question. Are you over here? Anybody?
There's a question back there.
Mark Pauley from the Wharton School. So, Senator Frist, I think this is a question for you. Palliative care seems like a good idea. It's always been a puzzle to me why some Medicare Advantage plan doesn't emphasize palliative care. Are there some regulatory impediments to doing that, or is it just a failure of imagination? I'd certainly want to sign up for one, especially if it was run by nurses too. What's stopping people from emphasizing something that seems so obvious?
You know, well, it's interesting. And the palliative health care, like all of these, because we want to solve things overnight, it's just hard to do. It's hard to do it at home. It's hard to do it anywhere. Palliative health care movement really started with, I don't want to say where it started, but the Robert Wood Johnson Foundation about 20 years ago. And George Soros, actually, he's been in the news lately, put a lot of money into it. And with that, the discipline of, it's a terrible word, palliative health care. On the other hand, I still use it a lot because it gets you away from, it's totally different than hospice, and it's different than acute care or chronic care. It's just different. So I keep using the word itself. And then you had to invent the field, define it. Why is it different? And it's totally different. We won't go into that, but totally different. You're still treating. Hospice, you've stopped the actual physical treatment. Both of them have mental, both of them are team-based, both have mental, spiritual, social treatment, but it's a totally different field. And then you had to take it to the medical schools for the first time ever and teach the trainers, or teach the people who be providers. And you're right, nurses are really run palliative health care. So when I say the doctors, it's really the nurses, you're exactly right, that are coming in. And then you have to set up a reimbursement of some sort for that. And that's where we are today, the sort of breakthrough where you can get a team of people responsible for one individual instead of fee-for-service, chaotic, no system, as Julie said, coming in. To put a team together, you have to figure out how to reimburse the team. So that takes payment reform, and that does have to be institutionalized by Congress. But no, it doesn't any longer because you have Medicare Advantage. And Medicare Advantage strips away a lot of the old regulations and gives a group of plans the flexibility. Say, here's the money, you implement this. So how many people are in Medicare now? 50, 60?
55.
55 million people are in Medicare now. Half of them are in Medicare Advantage. You can get good palliative health care there now. It is value-based. It is better outcomes. It is living longer. It is living more fulfilling lives. All of that's been proven. The other 25 million people in fee-for-service can't get it at all. They can't get it because they're still fee-for-service. It's fractionated. Now, you can get it if you're in a hospital, you know, while you're in the hospital, maybe for a few weeks after. So right now, our policy's got Medicare Advantage where you have this flexibility. All of them give some sort of palliative health care, just about all of them. I've contracted with probably 10 of them, of the plans. It's the 25 million people who have not yet been, in my mind, modernized, and they don't have access to palliative health care today.
Great. I think we have time for one more question, if it's a quick one, there in the back.
Hi, Dave Grandy from Penn. Social determinants of health. There's been a lot of discussion, and I think there are opportunities where you can get people coming together from the two parties, but then there's also times where people really deviate sharply. And so it's easy to talk about social determinants of health in the abstract. And I'm wondering if I just took an example in Philadelphia where I live, There's a lot of work done on tobacco right now, and the Department of Public Health has tried to restrict the number of outlets selling tobacco products, for example, and that set off a whole political fight with the state. And that's really looking at the environment of tobacco sales. And so there it gets very political. It's a real dogfight. So when we're talking about social determinants of health, like what are the places to start from where there really is not this partisan line that emerges?
That was what I was trying to ask. He just asked it better.
Yeah, I mean, I actually think that the environment makes a ton of difference, and really sort of thinking about those things that most negatively impact people's health that are very prevalent in their community. I mean, sugary drinks, we've had that battle going on in California and counties. Some counties have passed it. It's never made it out of committee in the legislature, and completely Democratic legislature. So, but I do think it's important to think about what the environment is that is around some of these determinants that then the healthcare system ends up spending a tremendous amount of money on the back end managing chronic diseases to be able to do that, and making that connection in policy environments is really important to do. You need evidence and data to be able to do that, and you need really strong advocates for it. We've done much better on tobacco. I mean, very much not like other parts of the country, very, very low smoking rates in California. But that was, we taxed cigarettes and sued the tobacco companies. I mean, really, it was a multi-pronged approach at doing that. And I think when you look at some of these very enduring toxic things in the environment, you need to be able to have multiple levers to go at them and try to address them.
I've spoken to, kind of in my rambling, several food. I think instead of coming in and shutting places down, that there are better angels out there, better incentive, better things to appeal to. Food deserts right now, my example, is an obvious place where policymakers planning and appeal to the private sector in partnerships coming together, where you don't have a 12 blocks by 12 blocks in a tough neighborhood where you have no access to, fresher food, better food, healthier food. There are social determinants in neighborhoods, coming back to geography, of looking where people come into emergency rooms between 12 and 4 o'clock. If you have that data and record that data and you see where they actually come from, to focus on that part of the city in terms of a free health clinic. There are a lot of both churches and nonprofits who have these clinics, but typically they're not located, and to give some assistance to do that. Transportation right now, the biggest impediment for women getting mammograms, just for example, it's not cost, which we all, to get the cost down, everything's going to be okay. It's not access in terms of, you got it in your plan. It's having a woman be able to go across town to get a mammogram and transportation. And there are simple, low-hanging things, whether it's Uber or Lyft or however it's set up, a transportation that's set up that could do more for breast cancer than making mammograms free for everybody. So it's that kind of thinking that we just all need to be doing when we talk cost and we talk access. And we've built into it, the U.S. Care's built into it. If you listen to Andy or you look at principle number 1, it's framed pretty much around the equity issues. Equity scares some people, so don't just throw the word out to anybody. It depends on some people. Again, in my part or our part of the country, you start talking about equity all the time. They don't know, what does that do? But the fact that's built into the principle, I think, gives you a lot of cover in terms of what we're talking about. It's not just the second principle, cost. And the access issue, you have to tie the equity into it. And that's the kind of social determinants that if we really want to improve outcomes, we need to be addressing at the same time we're doing our traditional access of a health care plan or cost itself. Build those social determinants into it.
All right. You want to add something real quick? We're out of time.
All right. Back to the magic wand for a moment. If I could wave a magic wand and do one thing in Kentucky that would change people's health more than anything else, it would be smoking. No question about it. We've got pregnant women smoking. It's a mess. But we've come a long way, and we're a tobacco state, just like you all were to an extent in North Carolina. But But over half our population now is covered by smoking ordinances, but we can't get a statewide one passed. But I think the senator's right. Finding positive types of things, even small things that you can do and affect one of those social determinants is the way to go, because it's so much harder to try to tell somebody they can't do something than help them to do the right thing for the right reasons.
Julie, before we wrap, so the Senator talked about equity and the concept of health equity and some people being uncomfortable with that. What does that mean? And I just think we ought to name that for people who hear equity and get defensive, there's a sense of you're going to take something away from me and give it to somebody else. And I think it's really important that we take that myth that that is not what we're talking about. We're talking about health equity. Yeah. That really what we're talking about are basic things: transportation, food, safe housing, and that we want everybody to have that. And I worry that we talk about equity and people sort of say, well, that means I'm taking from here to give to that. And I just think we have to get rid of that myth if we're going to continue this conversation and, importantly, make improvements in health equity.
Thank you. What a wonderful panel.
Thank you.
We're not taking a break. Next panel's coming right on up. So thank you all.
Good to see you. I hope you weren't in the room when I was saying pay attention to see you. You weren't anywhere.
I wasn't.
Yeah, I said,
Shut their door.
pay attention to those guys over there.
How are you? Good to meet you.
Good to meet you too. Where do you want me? Do you want Adam closer?
Yeah, why don't, let's see. Why don't you just sit right there and I'll put Adam there and I'll sit over here.
You sure?
Yeah.
Good.
Do you think it's better there? Yeah. Just so I can see, put Adam there.
Adam here?
Yeah. Mm.
Hey, I'm doing good. What's going on with you? Yeah, I'm looking forward to it.
What?
Can we get a little bit of... It's okay now? Okay. All right. Friends and colleagues, yes, we have an extraordinary panel now. We're seeing history in the making. And I was just commenting before that I have to put my glasses on in order to read Adam's titles to you, because he has more than one. Adam Bowler is CMS Deputy Administrator for Innovation and Quality. That should be enough on its own. Director of the Center for Medicare and Medicaid Innovation and Senior Advisor for Value-Based Transformation and Innovation at HHS.
Molly, the rule in Washington is the simplicity of the title dictates how much power you have. Powerless.
Right, yes. They just keep passing you around, right. And Dr. Mandy Cohen is Secretary of the North Carolina Department of Health and Human Services. And we are...
One title, more power.
Yeah.
Drunk on power. So this afternoon, our question is, a lot of the discussions that we've had and that go on about improving health and health transformation begin with coverage. But there's a heavy emphasis, more and more, and certainly one that US of Care is emphasizing very heavily, on how we're actually transforming the care itself, access to care and the quality of care and the nature of care and its cost effectiveness as well. And so that's the focus now with this panel. And so what we want to do is give people who haven't had a chance to hear from you individually to talk first about what your ambitions and your aims are for the work you're doing with your agency, to understand the CMI approach to this and what you're working on and accomplishing in North Carolina. And then secondarily, we'll move to the collaboration between federal and state as our emphasis. But if we could start first, maybe Mandy with you, about what your goals were as you came in and what you've accomplished to date and what you're excited about as you see in the future.
Great. Well, thanks, Molly, and good afternoon. It's great to be back in D.C. I see a lot of friends and colleagues and mentors who are here in this room. So let me give you a thumbnail on North Carolina before I launch in so everyone knows a little bit more about our state. 9th largest state in the union, fastest growing, 10 million people, very purple. We have a Democratic governor, who's obviously my boss, Roy Cooper, and a GOP supermajority in our state legislature, which is going to just change to just GOP majority starting next year. That means no Medicaid expansion, and also a decision by the General Assembly before I joined the North Carolina team to move the Medicaid program to managed care for the first time. We're the largest state that has not moved our Medicaid program to managed care. Hard hit by the opioid crisis, classic issues, urban-rural divide, racial ethnic disparities, really what I think is a model of what the country looks like. And that's why I find it really inspiring and challenging to be there and do this work. And my agency, when it says Health and Human Services, is actually referred to as a mega agency, meaning that in our department, we have not just Medicaid, but public health, mental health, including a number of psychiatric hospitals that we run. And then I also have the levers of the SNAP program, the TANF program, early childhood education, and vocational rehab and education. So as you think about the social determinants, or what I call healthy opportunities, I actually have a lot of those levers in my department. So what I wanted to focus on, I think, is how we are using our biggest lever, Medicaid, to do some of the driving towards that improvement that you were alluding to. And so as we make this change to managed care, we've really tried to embed 3 things in that transition in a very purple state, in a way that I think will demonstrate not just the state-federal partnership, but also the bipartisan partnership here. And so one has been, first, a focus on integrating physical and mental health, as well as an investment in primary care. So right now, the way we pay for physical and mental health is in many Medicaid programs is very siloed, and thus we get a lot of siloed care. We're bringing that together as we move to managed care, as well as making a pretty hefty investment in primary care and local care coordination. Second lever is really around value, and not just moving to a capitated environment, but making sure we move that capitated environment to one that includes alternative payment models. So we have some pretty aggressive goals for our soon-to-be managed care plans to move to alternative payment models very rapidly. And then the third is what we've gotten a little more national recognition for lately, is our focus on the social determinants, or again, what I'm calling healthy opportunities. Social determinants, for me, determinant feels like you can't move it. Opportunities feel like you can actually make some change. So we call it healthy opportunities, and I bet we'll spend some time talking about it, but that this is where we are embedding in many parts of the Medicaid program and beyond how we are thinking about food, housing, transportation, violence, and employment for folks and their ultimate health. And this all falls under the rubric that I've been talking about for a couple of years now as buying health, right? I have a $20 billion a year budget. It's not as big as some budgets. But I want to make sure I'm using every one of those dollars in the service of health. So when you ask me what my aim is, it's health. But that means we have to reorient very differently. It means we have to spend money on different things. It means we have to measure things differently. And that's what we're trying to do with sort of all of these pieces. It's in service of buying health. And I'm sort of excited about the places in which we've had the federal government and the state of North Carolina have partnered together on a pilot in the Healthy Opportunities space, a big one, $650 million pilot that I'd be happy to dig into, but all in the service of buying health.
Great, and we'll come back to that because that is obviously one of the things to ask about. So Adam, it's worth, I think my sound system's giving a little feedback. What I wanted to ask also is if you would comment a little bit about your move very abruptly from the private sector to the public sector. I've worked in almost every part of the healthcare industry, and my job as health commissioner in New Jersey, a government job, was still the best job I ever had. And second best was running the California Department of Health Services, where we covered double the people for 18 billion, so prices have gone up. But it'd be interesting to hear it from that point of view too.
Sure. So I'll give a little bit of my background to start, because it kind of pushes into that question, Molly. So before I joined here, I started a business called Landmark Health. And what Landmark is they're the largest provider of medical house calls in the country. So the business provides 24/7 in-home medical care, as well as social workers, pharmacists, dietitians, psych NPs, addictionologists. And so the business model is we would go out and take full risk for very complex chronic patients, and that would be Medicare, Medicaid, and duals, and then lower their costs by treating them 24/7 in the home. And one of the largest capitated groups in the country. So some of my familiarity in the space is from that, and what I was doing before I took the job in April was started and running that company. Now about 1,000 employees, about $2.5 billion of risk, treating folks, and it was a fully employed model. So we employed all MDs, NPs, nurses, and then the behavioral staff and social workers as well. And our experience was that when you do treat the whole person and when you look holistically, you do make a big difference. And I think, one of the areas here, I think a lot in my role now about payment models. I'm very oriented toward payment models because I think what you put in from a payment model perspective generally dictates the outcome. And when you pay people for doing the right thing, and what I would define the right thing is doing the right thing for American patients, so lowering cost, improving quality, driving choice. When you make it so that people make money for doing that, then they do that. It's sort of a human behavior thing. And so let me use a specific Landmark example. When we would have a 94-year-old patient that had 10 chronic comorbidities, maybe they were on 15 or 20 unique prescriptions, and they would call at 2 a.m. And have flu-like symptoms, the typical approach would be to send that individual to the hospital. And my grandmother, she died when she was 100. Part of the impetus of starting the business was I saw that. She was in and out of the hospital all the time. My dad is a doc too, but he couldn't manage her by phone in these areas. And she would go in and she'd come out worse off than she was. And you were thinking, what's wrong with the system? The hospitals didn't like it. That's not where they're making money. They're making money on procedure volume. Those are the patients readmitting. Nobody was doing well, and the healthcare system itself was suffering. But more important, my grandmother was suffering, and it was hastening kind of her demise. And so we thought, how could we do this different? Now, the difference in the Landmark case was when we had full risk and we had full kind of accountability for that patient that I gave you an example, instead of getting paid $150 for a visit, which, by the way, you cannot send a doctor to somebody's home at 2 a.m. on a Sunday for $150 without taking a massive loss. My cost was $700-800 to do something like that. You're talking on-call Sunday. But that patient would then be admitted to the hospital. They'd go in, usually ED. Admit rate of a complex chronic patient like that, I don't care if they had a hangnail. They're going to get admitted in the hospital. There's going to be a lot of tests. They're going to be discharged probably to a nursing home, maybe readmitted, and then start a significant decline from there. That's $50,000 of expense. Now you're comparing $800 to $50,000, and that's how the business model worked, and we took 20 to 30% of expense out. So that kind of bellies some of my experience in this. You asked, Molly, why I took the role. I was called by my predecessor, Patrick Conway, now in your state, Blue Cross Blue Shield, North Carolina. We were actively trying to take risk on Medicare patients. We only could take risk on managed care. We didn't want to do fee-for-service. Totally changes around your culture. As soon as you start doing it, it's hard to get out. So we wanted to take direct risk from Medicare. So we were working actually with Senators Cassidy and Whitehouse on a bill, and we were working with CMMI on a demo. And so that's how I knew Patrick. And he called me, and I remember I was on a run. I lived in Newport Beach. I was on a run, and when CMS calls you and you're on a run, you pick up because who did I kill patient-wise? So I was very nervous about the call and huffing and puffing. And Patrick basically asked me whether I'd consider this, and in a really nice way, I said no. And I said, I said no, truthfully, for two reasons. One is I had never viewed myself as going into government at all. Private market guy, honestly, pretty negative conception of the government and how slow and bureaucratic, and I would hate it. That would be what I would have told you a minute before that call. And he basically said, hey, why don't you come in and meet the administrator of CMS? I think you'll like her. And worst that happens is you meet the administrator of CMS. Like, that's not bad for business. I'm like, okay. Speaking my terms on that, maybe I will do that. And so I called my private equity backer, Francisco Partners, and I said, hey, I'm gonna go in and take this interview, but I'm not going to take the role. And I'll make a story real short. The reason I eventually did it, there's a few reasons. One is I did like, from a CMMI perspective, the ability to get things done without going through Congress on everything. And so for me, the big question was, I look back at myself and I say, hey, you're on this earth for a certain amount of time. If you're going to judge yourself by what is there because you are there, what wouldn't otherwise be there, judge yourself on impact, and you want to be proud of what you do. I thought this is an ability to impact hundreds of millions of people. And so I thought, if that really is like that, I should do that. And so that's eventually where I got around, was the ability to do it. The other thing I think that was really important is the alumni of CMS. A big decision like this, you speak to everybody, I think. I do. Any major decision, I'll at least speak to a few experts in the area. Here I'm leaving a business that I started that I love, that's very successful, that is making a big impact. And what if I'm leaving and I won't make a big impact where I am? The opportunity cost of that. I'm moving my family. We lived a block from the beach in Newport. It was nice. Weather just like this. The other thing was really important was the alumni. And I'll tell you, Andy, actually, I spoke to him early. Anytime you make a decision like this, you think, well, I'm going to talk to bulls and bears on this. I really want to get a comprehensive view. And Andy I designated as somebody that I respected a lot, but would tell me why not to do it, right? I mean, Andy's on Twitter sometimes. He sometimes makes comments about the administration. We know you love the administration. But I thought, okay, this is, and I wanted that. I wanted to hear why not. And Andy was completely the opposite. Andy said, Adam, you cannot let this opportunity pass you by. I know somebody like you and the impact you can have. And he was a very strong proponent. And I found that from a bipartisan perspective, there was massive support. And so Andy was very influential in that, as were a number of other people that were former administrators, former HHS people, former CMMI directors. Patrick was very influential. And so that's why I took it, is the ability to try to do that. In terms of our agenda, I worked with the secretary very closely. There are 4 component areas we focus on in value-based transformation, the 4 Ps. The first is activating patients as consumers. The second is providers as accountable entities. The third is payment for outcomes. And the fourth is prevention. And I can walk through those briefly, and then we could obviously talk more on the prevention side if you'd like, Molly.
Yeah, I think what we should probably do is let's go to the description of the waiver in North Carolina and how that connects with your 4 program areas. So maybe we should first get a description from you. I don't know what is my feedback here. So Mandy, can you give a quick description of that and more broadly of what it's been like working in the state level with the feds today?
Sure.
And I'm sorry, everybody should know, this is the first time they've actually met.
Met in person.
In person. We spoke.
Yeah.
We speak.
Yes.
Yeah.
Meeting in person. It's been, so when I arrived in North Carolina, given that we're a very purple state and
by the way, did you see it?
yeah, so you're nice. It was. I wanted to make sure I understood the needs of the state, and that we were mapping to the problems of North Carolina, as well as understanding where I can't do that work without the support of the General Assembly. And so understanding sort of how do we map a solution set to what was going on in North Carolina, but it's very much shaped by my own personal background as a physician, where I have similar to hearing your family experience, having a patient experience where I was seeing a patient and after knowing her for 8 weeks, ordering a lot of lab tests, ordering CAT scans of her belly, about to send her to a next specialist because I'm a primary care doc. I was thinking, well, this is beyond me. She looked ill, and this woman that I was seeing, she was a young woman, and after spending all of that money, my tech who checked in the patient, and I'm now knowing her for 8 weeks, said, I really think you need to ask your patient if she has enough to eat. And it still stings, and it still is with me, and it shapes a lot of the thinking that I want to tell you about related to the waiver, because I spent a lot of money in the healthcare system, and I didn't make her one bit healthier. And I went into that room and asked her a non-standardized question about what's going on at home, right? Not the kinds of things I'm going to require of my managed care companies going forward. But it was then where you're able to pull the threads of, as a young woman who was a full-time college student, had commercial insurance, so insurance was not her issue. But she had just left an abusive relationship, embarrassed about it, didn't want to call mom because they thought she was going to marry the boyfriend, and she was essentially living out of her car, and all of her money going to tuition, and essentially the shame of everything was keeping her from reaching out to get help. And you have your own personal cognitive dissonance of what's going on in your own body, right? So that whole experience, but once we were able to sort of move past that, I was able to help her and connect her to the resources that she needed, though I will say my clinic not set up to help someone for those kinds of things. So it was like a total panic when your patient actually says, yeah, doc, I'm running out of food, and I think we need to acknowledge that. But it really speaks to what's in the waiver. So again, back to that integration of physical and mental health, right? So she's experiencing trauma, and I did not recognize that. I was willing to scan her belly before I was willing to talk about trauma, right? And then the second part of our waiver, again, an investment in primary care and getting to care local, is that she needed help to navigate around resources. And so we want to invest there, and there's been a good alignment and collaboration. But then, at the end of the day, what's going to make her well was not another specialist visit, but was other kinds of resources that we needed to build around her in terms of food and transportation and other things. And so that's what we're trying to do. And I think the most notable part of our waiver is this new expenditure authority that we are getting in our Medicaid program. It's $650 million. And I keep saying that because I'm proud of the magnitude of that investment, because I actually think it can help us learn. And it is a pilot. So it's very much, we built this as an opportunity to learn about what can really move the needle in social determinants or healthy opportunities. I hope you all start using healthy opportunities. So the first thing I did when we were starting to think about this was hire researchers and evaluators, because I want this to really be something where we can learn real lessons. And the idea is also to use managed care in that infrastructure. So that's the reality. Most Medicaid is now managed care. So let's build on that infrastructure and the way that and what does managed care do? I mean, essentially they build networks, and then they assess patients for care, and then they authorize services. So let's use that. That's great. So we built that pilot into the managed care infrastructure, and then are going to basically pay for food or housing or transportation interventions that have shown that have evidence base that can work. The classic example is asthmatic kids, right? Where asthmatic kids who are pretty severe get a lot of their care, unfortunately. The emergency room. Where's the most expensive place to get their care? The emergency room. It's not coordinated, it's expensive, mom and dad miss work, kids are missing school, right? The worst of all of that. So what was piloted in North Carolina, as in other places around the country, was an intervention around carpet So they went to the kids' home, ripped up the carpet, put down new carpet, and gave them an air filter. And not surprising to anyone in this room, right, a lot less ED utilization, so a lot less cost. Classic to what Adam was sharing with his grandmother, right? You need to go at 2 a.m. That's what you just need to do. But if I started by saying, hey, I have a great idea, I'm going to spend Medicaid dollars on carpet, they wouldn't let me keep my job. But we have good evidence, and it's a close also time sequence in that asthmatic, right? You get a really quick intervention and quick result, and I know what I'm measuring. But I really think we are still data poor on knowing what is that right intervention for example, high-risk pregnant moms. I care about that a lot in Medicaid, right? I pay for half the births in North Carolina. I pay for 80% of the NICU care in North Carolina. I care very much about how mom's pregnancy outcome is going to go, both from a cost, obviously, and a quality standpoint. And so, but I don't feel like we have the evidence right now to say, okay, when pregnant mom has these kinds of issues, you give her this kind of intervention. And that's what this pilot is hopefully doing. Not just saying, I'm going to throw the kitchen sink at everyone, because we can't buy, I will tell you, both of us sitting here, we do not have the resources to buy everyone a house and everyone a car. That's not going to happen. So we have to come up with what is that lightweight intervention that can actually move the needle towards health. And so that's what we were trying to set up, and I'm pretty excited about it. It means a lot of work still to be done, and I keep, stay tuned for all the details. But it was a great partnership with CMS. Appreciated. Administrator Verma was integrally involved and pushing us to really refine and hone and really know what we were going to test, as well as linking payments to value over time. So I think we have a lot of the infrastructure there to really learn important lessons. And we were able to do that with the 1115 waiver authority. So we actually didn't need to use the CMMI authority. But again, if you want to think about other populations, the Medicare population and duals, our pilot will not get to those populations. I think that's where the Innovation Center in the next sort of turn of the crank is going to be.
So Adam, how does this fit into what you're seeing? You've probably got a number of other pilots out there that you're testing for similar kinds of purposes. How does that fit in with your work?
Yeah, I think Mandy's approach fits in a couple ways. One, I'll give kind of a general philosophy way and then talk a little bit more about the fourth P, prevention. So just philosophy, our view is it's really hard for us to centrally manage risk for the United States. Thinking about, a state like North Carolina, right? You have there's three major cities. Is that what it's tri-city or whatever? Sure. Right? Whatever.
If you're there, it's
yeah.
5. But
5, okay. Well, here, look, see? I have no idea. Problem. But I think, you look at a state, you have a number of different cities. You have rural, you have suburban areas. North Carolina is completely different from Hawaii, which is different from Alaska, which is different from Ohio, which is different from New York. And so how, at a federal government level, do we manage that and create programs that are supposed to speak to everybody? One system we sometimes compare ourselves to or we look at as a cool model is Singapore, and there's some really cool things that Singapore does, by the way. I mean, they're a quarter the spend of GDP that we are. They do a lot in prevention. However, it is a 4 million person population that looks fairly similar relative to our diverse population in the United States. You cannot centrally manage that. And so part of our view here is let's get risk out of the federal government hands and push it local, whether that's a state, whether that's a managed care entity, whether that's an accountable physician group, to populations to groups that understand the local population, that can tailor care to that local population, that we can give kind of flexibility to do what they need to do, but then also hold their feet to the fire from an accountability perspective. So that, I would say, is a general philosophy, which is we've got to get folks that understand patients that accountability to drive it. So that's one. The second thing, and which is why I think this waiver fits so well in, the second thing from a prevention perspective, so CMMI has a lot of different goals. We have a lot of goals at CMS to reduce cost while improving quality. We spend between Medicare and Medicaid close to $1.2 trillion a year. And if we have really good goals, let's say we take out $100 billion a year. It's a lot of money, but then we went to 1.1 trillion. It's not, groundbreaking in the scheme of things. How do we get to 500 billion or something that's really impressive? You prevent disease before it occurs. And that really is a huge focus, and I'd say it's a few things. One, it's looking at a whole person. So exactly what Mandy's talking about in terms of an integrated view. And when I was at Landmark, there were countless times where we would identify and say, here is somebody that doesn't have a home, that's homeless, that is constantly going to the ED, and we were prevented as a capitated physician group sometimes from paying for some of those things. Or I look at like Geisinger's program around a pharmacy with an F, where they're giving free food to diabetic patients and lowering cost, but kind of really walking the line in what is allowed within Medicare. So I think one thing is allowing people to think about somebody on an integrated level, especially if they're accountable for that population. I think Mandy's completely correct. It doesn't mean, and this is from a Landmark perspective, everybody couldn't get 24/7 concierge care, right? That's concierge care. You pay for that if you have a concierge doctor. But really sick folks do need that, and it pays for itself. It more than pays for itself. We weren't a nonprofit. We did very well for doing the right thing. So I think one is looking at and giving people the flexibility to think beyond medical, because so much of those elements impact medical. The second is we want to think about certain public health initiatives that look at prevention. And I'll give a specific example, and that's the application of artificial intelligence in healthcare. So I think it's very nascent. Healthcare as delivered by doctors is much more of an art than a science. And healthcare is a science. It's all just very complicated. And so we're looking at saying, how do we drive an analytic approach to healthcare and make that more pervasive using the scale of CMS? And so I'll give you two examples. One, we saw a very interesting study that UCSF and Google did around quality. What they did is they looked at derived measures of quality, and they used artificial intelligence, and the net result was not only did they come up with much better predictability than our best quality measures today, they were all derived, so there's no burden on clinicians, which fits right into our idea of patients over paperwork that the administrator is pushing. And so we're going to do a challenge. We're going to do $1 million challenge to identify how can we leverage AI to reinvent quality across the country. And our one criteria that is, in addition to it's got to predict quality better, it's got to be derived, it can't be too black box. We've got to be able to understand it so that clinicians can improve on it. We're also working with a number of AI vendors now to think about how can we get people to a base level of proficiency here. Simple things like probability of somebody that is going to admit in the next 30 days, presence of CKD, progression of CKD to end-stage renal disease. Relatively simple things to predict, but again, you're dealing with a ground zero of nothing generally here, so how can we create that?
It's fascinating. Sometimes when I'm sure sitting there, you're thinking if you brought in AI and started talking about how you were going to use AI, that might slow down your current efforts to build, even if it could really help you. How do you balance the policy drive to try to bring all of the state along and the tremendous differences in the competencies of different provider groups? And how do you think, Adam, about the question, I apologize again, I'm hearing this, the question of delegated risk? Because in general, most providers out there have no delegated risk. It's at the level of the MCO. But I think from a policy perspective, it's really interesting that historically we have very convoluted ideas about this at the state level and federal. But you're creating an intermediary organization, I think, for the social determinants work. Maybe if you could describe that first, and then we'll go to Adam and then open it up for questions, okay?
Well, why don't I speak to your first point, how do you bring the whole state along? And I'm in a state where coverage is very partisan, but working towards health as well as strengthening our Medicaid program and moving towards efficiency is very bipartisan. And so what I've tried to do since being in North Carolina is to focus on those places where we have alignment. And there has been alignment and multiple pieces of state law passed since I have been there in partnership with me and the General Assembly to integrate physical and mental health, to move forward on primary care investments, to move towards value. And I think you're seeing the support from the administrator and from CMS on healthy opportunities work, that bipartisanship there as well. And I think it starts by focusing, again, on the alignment, and I think the earlier panel really touched on having folks understand things from a different lens and a much more personal lens. The same folks who don't want to expand Medicaid in North Carolina have communities that are deeply impacted by the opioid crisis. They know that we need to do better. They have rural hospitals that are closing, and they know we need to do better. But they are truly worried about busting the state budget. They can't take on debt like the federal government. And so they want and are looking for these solutions where we can drive towards value and drive towards efficiency. We share a lot of that. And so those are the places that we've focused on, and that's been able to be good, which means also as we move into this healthy opportunities work that we have to avoid the pitfalls of fee-for-service that we've been in. So as you think about moving forward, and I'm saying monetizing, but paying for things like food and housing and transportation, we have to think about it differently and skip over some of the lessons we should have learned earlier in fee-for-service and really think towards value early. So you'll see in our pilot very much linking things to outcomes and then flowing that down in a shared savings arrangement to some of the actual vendors who are going to provide food and housing. We can't do that right away because there's some learning curve that we will have to do because we've never done this before. But we definitely want to move to bundled payments and risk contracting even in the social determinant space. I do think we need a little more data and evidence before we can really turn that on and turn up that dial. But we've already built it into our model to look at in the sort of the second half of the work.
That's terrific. Adam.
You're talking about delegation, and so what I would say is, to date, there hasn't really been the ability to take delegation from Medicare. Medicare Advantage, you can. And about in MA, probably 30, depends on the region, 30 to 50% of patients are in primary care delegation that are either capitation or 50 up, 50 down deals. And so, I mean, it's exactly actually what we were trying to do at Landmark when I was talking to the federal government about it. So I would say I would divide the rolled up very simply in that way into two categories. One is delegation, or real delegation, real risk, what I would consider capitation or 50 up, 50 down, and we need to enable that and assume, given our scale, again, you have a market of larger, more sophisticated folks that can do that. That's in that 30 to 50% range, because that's what it is in MA, and those people will open their doors when they can if the construct is right. Then you have 70% to 50% right of folks that not only can't they take delegation or real risk, I would argue they shouldn't take delegation or real risk. If you're a single physician, that's not appropriate. I view kind of risk as dealing jewelry in the diamond district, right? If you don't know what you're doing, you're going to get fleeced. And that happened back in the 80s and 90s where you'd see kind of groups in California when it was first coming up really jumping into this without, and so I think it requires sophistication. Now that said, you do not need to pay those folks on fee-for-service. Fee-for-service is what is driving a lot of this. And so let me give you an example. You think about primary care, you can create very simple outcomes metrics. They don't have to be that complicated. You can look at paying somebody a very simple fee, eliminate all this coding for revenue cycle, have some downside that is associated with risk-adjusted admissions, and have some real upside associated with risk-adjusted admissions. Not small money. And the good thing about PCPs is they're not paid that much as it is. They control a lot more cost. And so if you start saying, listen, instead of $200,000 a year, if you are keeping people out of the hospital and taking care of them, you're going to make $300,000 a year. That's real money. And that will, it will change around, again, what I was saying earlier, kind of everything is driven toward patients. And I was speaking recently and somebody said to me, well, I understand you're saying payment models, but we don't have enough geriatricians and people don't have enough time to focus on these people and this, and so they should be paid, $20 for each 15-minute phone. And it all roots back to payment. The reason we don't have enough people focused on complex chronic patients is because it doesn't pay well, just to be clear, right? It's because today's environment, if you're a PCP, for the most part, if you're not employed, you have to churn and burn and spend 15 minutes with the patient that's been teed up. And when a complex chronic patient comes in, you think, oh shit, now I have to spend an hour with this patient that may not even show up, and I have no real ability to take care of them. And I do believe the vast majority of physicians go to medical school because they want to take care of people. And so the key is not paying somebody for a 15-minute phone call. It's to say, look, if you're going to make a lot more by taking care of patients and keeping them out of the hospital, you won't have the voicemail that says call 911. You know, you'll respond on the weekend when somebody emails you and is sick. You will do some of those things that today you really can't do. It's really hard to run a practice and do that. So those are the kind of, so I would think, Molly, in terms of outcomes, exactly what Mandy was saying as she's thinking about things, which is depending on the level of delegation you can take. If you're taking full accountability for a patient base, we've got to let you have room to run. We've got to look at waivers that say, listen, you can really invest in things that others can't because you're really taking accountability here. If it's outcomes-based, there's a different approach, maybe a little bit less on the waiver side, but let's stop paying people based on an activity because that's where I think the root of our issues is.
Does that make sense to you too?
Some. But what I do think is that there is a huge amount of data infrastructure that I think it will take to allow physicians to have that right ability to have the information they need to do the right thing. In addition to the payment incentive, I definitely agree on the payment. You get what you pay for. The reason we get a lot of hospital admissions is because that's lucrative. And it's not malice, like it's not doctors being malicious or not doing the right thing. They're working within the system that we've created. And so you have to move the payment levers. And that's why I think also that this is the right time to think about the healthy opportunities. As you're thinking about outcome-based, I think this is the time that you can make that stick. We're not the first two people who've ever thought about, hey, food's important and having access, right? But you have to pair that evidence with the right payment levers. But I do think, as I'm thinking about our own North Carolina implementation, what is holding back our provider community from feeling like it can take on more risk is some amount of data infrastructure to really know who is theirs. What is their downside, and how did that, and how do they mitigate? And I will say, as a physician, we're all risk-averse people, and I shouldn't say all, but we are majority risk-averse people, right? We do things to make sure that the worst doesn't happen, right? That is how we enter the world. If I thought about that patient I talked to you about, like I was worried about cancer, right? And she had food insecurity, right? But I was worried about the worst thing, and you just have to know that it's a psyche. And so if that is the issue, I think data and infrastructure, they are scientists, and I think really do want to see their data and their patients, and do respond really well. When you say you're an outlier, you actually order way more head CTs than all of your doctors around you, they go, really? Mm-hmm. Well, first the data's wrong, and let me dig into that. And then they were like, oh, the data's right, and like I'm going to change my practice. Mm-hmm. So I just would add to that a caveat of thinking about both at the state and the federal level, how do we support an infrastructure of that good data exchange where people rely on it, can do the risk adjustment needed to get that all right. But otherwise, in terms of payment incentives, I totally agree.
Great. Well, let's open it up for questions and comments. Emphasis on questions? Yeah.
So you just began to touch on it there at the end. But one of the things that I always worry about when building these, risk-sharing, reward-sharing models is sort of that risk-adjusted payment and the attribution model. What patients are attributed to you, because if we don't get the data right to be able to do that, the care systems will begin to get ahead of our payment systems and be able to select the populations that they're going to be able to achieve the savings that they're looking for on, and we will wind up underserving the people with disparate outcomes yet again, and our systems will fail. So trying to keep data ahead of these systems and be able to appropriately risk adjust and build the attribution models to allow the systems to understand the risk that they're taking on better are two of the key data pieces that I try to watch. How have you worked to address those?
Yeah, I think that, I'll give you an example. And again, it really depends if you're talking about, more delegation, full delegation, or whether you're talking about outcomes-based orientation. But a good example is we have our CPC Plus, Comprehensive Primary Care Plus initiative. We have 2 tracks now, track 1 and track 2. We're looking at a 3rd track that's much more outcomes-oriented. And there we have kind of a web-based tool that will show kind of them from a claims perspective, where they are, where outliers are, what it looks like from a risk-adjusted payment perspective. What I will say is, and it does some fairly simple kind of, here are your top cost cases. The problem with that approach is why we're oriented toward looking at artificial intelligence is your high cost cases generally, there's regression of the mean. And so looking at that as a fairly basic thing to say, these are my really high cost people, because not everybody comes back and is high cost. There's a fairly decent regression. At the end of the day, I would say the biggest issue, in my opinion, I think data is important, attribution is important. What I will say is it's very hard to operate in a system where you have a foot in both camps. And I believe that is the biggest issue. And what I mean by that is it's like kind of a blockbuster Netflix issue. You have folks that are either not fully committing, they're still on fee-for-service, maybe they have some upside, they've got multiple different models, they're being paid this way by commercial, this way by Medicaid, et cetera. So I think our job at CMS is, what do we have mostly right now? Scale. We have a lot of scale. And so when you look at the administrator and her push and looking at rules around ACOs, people say, why are you doing that? ACOs are in there. Why are you looking at eliminating upside only? There's some savings. What's the negative? And the negative is people don't commit. And so I think the key here, this is the most important thing, because ultimately I'll tell you statistically, like when we introduce CPC Plus, somebody will have 2,500 patients attributed, and they'll come to us and they'll say, these 5 patients, this or that, or that. I'll tell you, it doesn't statistically make that much of a difference, especially if you're working in quartiles. The key is having a volume that is really paid that way and committing 100%, or not, for that matter. I will tell you, value to me is not risk. It's not capitation. It's not, value is lower cost at higher quality. And so I'm actually quite fine with somebody saying, you know what, I'm not going to be a Kaiser. We're not going to taking delegation. But as long as they have a foot in both camps, kind of quasi-taking delegation, that's not good. So we're trying to force a choice. So if anything, I would say that scale and that commitment is going to be very important to driving improvement.
And if I could add, I think that the payer alignment is really important here. And I think that's why in North Carolina, I am very hopeful on our success, because this isn't just Medicaid doing, right, Patrick Conway being at Blue Cross Blue Shield North Carolina, and this is the one time I'll say insurance consolidation is helping me here, because he owns 80% of the market in North Carolina, but you have what we're trying to do in Medicaid, his commercial business, as well as where Medicare is headed. We have a lot of Medicare Advantage penetration in North Carolina. And so there is a lot of alignment. And so I think that's right, that there is a tipping point where a practice and a health system says, okay, I get it. I know where it's going, and we're in. And I'll say this has not been the case in North Carolina. Very few entities are taking any sort of downside risk at all in North Carolina, but they see where I'm headed, where Patrick's headed, where Medicare's headed, and they're like, all right, time to get serious. Time to, okay, what does this really look like? Let me get into the numbers. And the other thing I would say on this is that we have found helpful is that there are a number of vendors that are now, they've called themselves like the marriage counselors of downside risk, which I think is helpful. There's some distrust between payers and providers. Don't know if you knew that. Some distrust there, and sometimes a neutral third party that is not the government, that is not a payer, but that can help be a neutral arbiter between, okay, how are we going to set the price here? How are we going to set the parameters of what this risk contract looks like? I think has been helpful in North Carolina context, and we will continue to use those kinds of facilitators to help us on attribution and help us on those kinds of things. That has been helpful. But I think the moment in time and the alignment that we're all moving in a direction is also helpful for the provider community. They're like, okay, but stay there. Yeah. And I think to the earlier comment when it was like, when HHS under previous leadership was maybe moving away from that, they're like, okay, maybe I don't have to commit now, and now it's back, and so, okay. So again, I do think that commercial Medicare, Medicaid alignment is really helpful.
One other thing I'd add, and I think this is important too, I agree with what you said, Mandy. The one other thing I'd add is there's a bias, or there's a fallacy that is important for us collectively to kind of get rid of, which is that in order to take any kind of outcomes risk, you must have control over everything that happens with each patient. You know, I can't control. Yeah, that's right. You can't. I can't. You know, the key is when you have enough of a sample, and that's where I mentioned risk-adjusted admissions as a simple metric for a single physician. The reason we chose that, we could choose risk-adjusted total cost of care, we could choose risk-adjusted nursing home visits, et cetera. Because risk-adjusted admissions is, one, it's very simple to understand, keep people out of the hospital. And two, it's statistically relevant given the sample size, meaning you can't stop everything. Nobody can. You're a doctor, not the person. Not everybody's going to listen to you. But the key is improving where it is, right? And so things are going to happen. If you're a good doctor and you're giving care, are you improving where it is? That doesn't mean you have to do it. And I'll say, like at Landmark, we had about a 55% engagement rate. That means 45 to 50% of the patients we never speak to. We couldn't get them on the phone. And we had full risk for that population. So people would say, Adam, how would you take full risk? Half of the population. But that's not important. Half of the population is going to revert to the mean. It's the 50% we do touch that drives an overall 30% cost decrease. And so that's the key there. You don't have to control everybody. You've got to overall make an impact, if that makes sense. And I think that's something people don't always understand.
I hope people picked up on the math of that, because it's very important in all of these. So unfortunately, we're out of time. I see other hands up, and I'm sorry we can't call on you, but it was a great, great panel. Thank you very much. Okay.
You're allowed.
I'm going to ask one question.
I could never control it.
Just to close, yeah. Good luck. I know what you guys do every day. I have a sense of what your days and your calendars are like. The people that you tend to see, that you tend to meet with, are people running hospitals, physicians, people who are controlling resources and assets. And one of the reasons why I think you're such an important panel is because we all feel so powerless in healthcare. We all feel like we can't affect the change. And you're two of the people in the Medicare program and the Medicaid program that actually have your hands on the steering wheel to the extent that many people do. So who you talk to, what input you take, and how you then prioritize become really interesting decisions when you're in a chair like you're in. We've got people in this room today that are patients, that are parents of patients, and that are patients themselves. Probably don't know half of the three-letter acronyms that were mentioned here, and probably shouldn't need to. So I guess my question for you is, we think about the next 5 years of moving healthcare forward, how do you meet the challenge, the very high challenge, to make sure you're taking patient impact and the voice of the patient and families into regard as you do your decision making? And what are the practical things that we can all do better? Because I found it important but very challenging to do when I was there as well.
Why don't I start, because I'm sitting in front of Natalie, who is an amazing mom and advocate in North Carolina, and quite the Twitter star, tweets at me sometimes, as she well should. But there's a couple very concrete ways. So first, as we've moved into our Medicaid managed care transition, one is that we brought the patient voice into the room. We literally invited a family to come to our all hands, all 800 of us meeting as we were doing our work, because we need to hear from them first. So that was number one. But it's also grounding us back on that simple focus of buying health. Right? I think we can get caught in all the acronyms and the payment limit, but at the end of the day, we want our families to be healthy, to be safe, right? Your daughter is an amazing inspiration. And it comes back to also, I will brag on my governor for a second. He has a very simple mission statement. He wants a North Carolina that's healthier, that's better educated, that has more money in their pocket, so they can live an abundant and purposeful life. Right? That's a huge charge, but it's what I think about every day and we ground back to. And I think it's really important to make sure that we are building intentionally that patient voice into the work and ground back to health, and not health care, because we can kind of get all embroiled in that. But thank you to United States of Care for thinking about that in a very intentional way, and I think we can always continue to make improvements there.
A couple other thoughts. One is, I'll tell you something I do like about this job, which is, people come to us, obviously, and everybody, rightfully so, has a specific perspective, right? So they'll have the perspective of their industry, et cetera. Your job is to only focus on the American patient, right? And that is the lens that you see everything through. And so that's nice. And I will say, one positive about the current administration is that the current administration doesn't really care that much about other stakeholders. I don't feel like when we're making a decision and blah, blah association will be upset. Doesn't mean we don't listen to them in the context of patients, et cetera, but the feedback I get is if it's the right thing to do for patients, do it. We don't care. And I always feel like, well, go have a conversation with the president, enjoy that. But it does let you be myopic about what is the best thing for people. And so I will say it is always what we think about is this going to result in better quality, lower cost, and more choice and access for patients? That's 100% of what we think, and I like that about the job. The final thing I say, I didn't really focus on all the P's. The first P is patients as consumers, and just to reflect on that in the context of your question, the real focus there is how do you empower patients to choose more of their health care and get more of the direct benefits. I think one of the issues of health care is if you invest in your health care, it's not like Facebook where you sign up and you get an instant reaction. It's decades down. And so how sometimes patients make choices that are better cost, better quality, et cetera, and don't get any of the benefit of that. How do we make this more of a consumer-oriented approach where patients get some of the benefit? If they choose a high-quality, low-cost provider, and that's their choice, how can we let them share in some of the economics of that they wouldn't otherwise see? How do we make it feel like it's them making the decision? You have doctors that are counseling them, but they sit in the driver's seat and they get some of the benefit. How do we stream that to them? So that's another thing we're thinking about a lot to drive on the patient side.
Okay, can we stop now? Thank you very much. Thank you.
We're adjourning for a brief break, about 15 minutes. And just a reminder, when we get back, we're going to be teeing up our small group discussion. So if you aren't already sitting at your assigned table that's on your name tag, please find your way there after the break. Thanks.
I'm Kristen Wakilius. I'm the Senior Director for Policy here at United States of Care, and I'm here to give just a brief introduction of our next panel, which is going to focus on the building blocks of change. So throughout the course of the day so far, we've talked both about facts on the ground right now and also the vision of where we want to go over the next several years. But achieving the goal of making sure that every American has access to affordable health care certainly won't happen overnight, and it can sometimes feel impossible to know where to start when you're working in pursuit of such a large vision. So at this point in time in our day together, we'd like to transition into the practical and talk about the steps that we, United States of Care, and all of us in this room can take now to lay the groundwork necessary to accomplish our mission. These so-called building blocks will span policy and academia and politics and advocacy, and will help lay the foundation for a new and better system that we all believe is possible. Our panel, representing the diverse perspectives we have in the room today, will help us do that, offering the voice and points of view of the academy, patients and their advocates, and on-the-ground policymakers. We also want to make sure to capitalize on the tremendous amount of experience and insight from all of you that we have gathered in this room today. So after the panel's discussion, we're going to move to informal discussions at your tables to talk about these building blocks of change and to get some feedback from you on a few other key important questions. And so many of you will have a team member from United States of Care. If there's not someone already at your table, someone will be joining you to make sure that we're taking advantage of the wealth of knowledge that we have here and capturing all of your thoughts. So no need to worry about taking notes during your discussion. We'll take care of that for you. And we really appreciate the feedback that we're going to be getting. We think it's going to be very, very important to informing our work, our research with our research partner, Penn LDI, and the policies that we work to pursue in the coming year and years ahead. So with that, I'll introduce our panel. Our moderator, Dr. Dave Grande, is an associate professor of medicine at the University of Pennsylvania School of Medicine and director of policy at the Leonard Davis Institute of Health Economics. His research focuses on healthcare for vulnerable populations, with an emphasis on identifying and overcoming barriers to care, and he also studies ethical issues related to marketing and healthcare and digital health information privacy. And in addition to his academic work, Dave is a practicing primary care physician. Elena Hung is the president and co-founder of Little Lobbyists, a parent-led organization that advocates for children with complex medical needs. She'll talk more about their work, but so far their advocacy, guided by Elena's leadership and vision, has already had a significant impact on the national healthcare debate. And in addition to all of her healthcare advocacy work, Elena also works as an immigration lawyer here in Washington, D.C. And our next two panelists are also currently serving as United States of Care's inaugural policy fellows. Jason Helgerson has more than 20 years of public service experience, most recently serving as New York's Medicaid director for 7 years. And prior to his time in New York, he served as Wisconsin's Medicaid director. Jason now works with companies, providers, payers, and governments in his work at Helgerson Solutions Group, the consulting firm he founded. Then our final panelist, also a policy fellow for United States of Care, is John McCarthy, who was most recently the Medicaid director in Ohio under Governor John Kasich. And prior to his time in Ohio, he served as the Medicaid director here in Washington, D.C. He is currently a founding partner at Spire Healthcare Strategies based in Nashville, Tennessee, and is a nationally recognized expert in Medicaid reforms, delivery system design, and systems implementation. So Dave, I'll turn it over to you for the panel. Thanks so much.
Thank you. Is my microphone on? Okay. So we have a very easy charge here in 30 minutes, which is to try to take a lot of the discussion that happened here today and think about some more immediate building blocks for the future in a way that I think Andy spoke to this morning in terms of setting the stage for these next steps as we think about health reform in the future. But I want to take a step back to start and take a moment to reflect a little bit on what's happened over the last year and a half and ask you, Elena, you played a very important role over the past 2 years in mobilizing the patient voice, the advocacy voice, around the whole debate around Medicaid, around the debate around ACA repeal. And can you tell us the story of Little Lobbyists and from your time organizing what worked and what we can learn from that effort in terms of looking to the future?
Sure, thanks. So first I'll say thank you everybody for being here. It's been a really exciting day, starting with Andy's intro and focusing on patients. And in every single panel, we heard the stories and the voices of patients, and I think that is so, so important. I often describe myself as an accidental activist. I didn't set out to do this. I didn't set out to be on this stage. I have a daughter with complex medical needs who was born with a number of health issues. And in 2017, when we saw Congress threaten the health care of millions of Americans, I felt the need to speak up. Long story short, I showed up. I showed up on Capitol Hill. I brought my daughter. I wanted members of Congress to meet her and meet children like her to see what healthcare made possible and what was at stake without it. So looking back in the past year and a half, which feels like a decade or more, what was so important were these personal stories, not just mine and stories from other parents like me, but we heard from the disability community. We heard from people, from cancer survivors. We heard from those who with chronic illnesses. We heard from other caregivers. Those personal stories put a face on healthcare. I would like to think we made it very difficult for members of Congress to turn away. We took the data, we took the CBO scores, and we put a face on it. And I think that that is just something that's so incredibly powerful and that we need to continue to do.
So a question I have for all three of you is that the politics and the dynamics of thinking about advocacy around policy is very different when one is trying to defend the repeal of a program or to defend against cuts to a program versus a more forward-looking agenda, which is about what changes we want to see coming forward, ultimately moving toward the vision that Andy outlined this morning. So how do we think about, in some sense, the work of Little Lobbyists and others to begin to transition from going from defense to offense in terms of policy? And maybe I'll pick on you again, Elena, but maybe we can start here and move down the line.
Well, my perspective as an advocate, as an activist, the first thing I'll say is that my activism was a privilege, right? I was able to come to Capitol Hill, bring my child who's in relatively good health despite her medical conditions, and make our voices heard. Not all voices were heard. And we can't just listen to those who are able to show up like me. We have to center this conversation on those who are most affected. So I just want to say that up front. Switching from defense to offense, to the people who show up and speak, we have to seek them out. I think it's really appropriate that we are here today on the International Day of Persons with Disabilities. And the voices of the disabled community is a voice that has been historically marginalized, currently marginalized and historically marginalized. And that must change. We must be inclusive. We need to seek out those voices. So I think that's the very first thing that we need to do as we move forward.
First, it's a pleasure to be here today, and it's been a tremendous day so far. So I guess in the way I look at sort of the healthcare debate in this country, where we are right now, is I sort of split the issue of healthcare into two topics. The issue, unfortunately, of coverage and getting to a point in this country where all Americans have access to health insurance has become highly politicized. And I think that for those of us who have advocated for universal coverage, I think we have, at least in the last year and a half, won the day. And meaning, when I say won the day, we've maintained the Affordable Care Act in its current form, strengths and weaknesses, but at least we've defended the coverage expansion that it brought, which I think overall, from my perspective, is a very good thing. But I do think that the politicized nature of that debate isn't going away, unfortunately, anytime soon. So I don't think there's going to be a lot of movement in this town, other than maybe for us to continue to be vigilant to protect what gains we've gotten. I do think, though, that there's opportunities at the state level. That's one of the things I think about the United States of Care is, and its mission, and why I wanted to sign up for this organization was I do think there are opportunities, and we've seen a number of states, whether it's through referendum or state legislative action, or even in some cases even just gubernatorial direct action and such, is the opportunity to see coverage expansion at the state level. There's still some big states out there that I would love to see move into the coverage, full coverage area. But I think the other aspect of healthcare that we just saw discussed in that last panel is about delivery system reform. Because ultimately, at the end of the day, you can give someone a health insurance card, but if they're trying to go out and buy healthcare from a totally dysfunctional, inefficient healthcare system that's generating terrible outcomes when you compare ourselves against any other country in the world, in the developed world, and that's the reality of what we're facing today, is that insurance is not worth as much as we collectively as a nation are paying for it. And I think there's tremendous opportunity, and maybe the unique, strange politics of today creates that opportunity. What Adam Buller said earlier, I was the New York State Medicaid director in one of the bluest states in the country. I have literally used exactly the same words that he said. I was saying to John earlier, I can't remember a CMS federal official standing up in front of an audience talking for as long as he did, in which I could have said I agreed as much with his statements. And that includes all the years of the Obama administration, and I was a Medicaid director back in the Bush administration. So I think there's actually a lot of opportunity at the state and federal level. We saw North Carolina as a good example, that we can actually see some positive change on the delivery and payment systems to hopefully drive the overall healthcare system towards a more cost-effective plan.
John.
Yeah, for me, it's really looking at the states, looking at what states are doing, and in your question of then how can we get on the offensive on some of these different pieces. I think one of the things to think about is within your state, going to legislators to educate them on what is covered, what's not covered, and putting a face with the individuals who are not getting coverage, who are getting coverage. I was sitting back in the corner with a state senator from Minnesota, and it turns out there's 67 senators in the state of Minnesota, state senators. In Ohio, we had 33, and I thought that was a lot. So, and you have to educate all of them. And just a couple of quick things. We live this world every single day, so we know all of these things. I will tell you, in Ohio, when we were talking about expanding the Medicaid program and going and talking to legislators, the conversations were very interesting because what they know is very different than the reality of what the world is. So when you say, oh, we want to expand the program, and they're like, well, why do we need to do this? This is just for childless adults. They thought a childless adult was somebody who never had a child. They did not understand that it wasn't a child at home. So they were like, well, yeah, but everyone can get on Medicaid. You were like, no, not everyone can. So you had to go through some of those things. Then after we did that, and for states now, and thinking about different things, bringing data to entities to say here, and we talked about fake news earlier, but finding really good, hard, strong data to show here's what we need to do and why we need to do it. And I'll just give you a quick example. In Ohio, when we expanded, we added 700,000 people to the program. We found when we ran the data on that, there were 20,000 people in that expansion population within the 6 months when we looked at claims from there who had a diagnosis of cancer or were seeking cancer treatment. Those 20,000 people probably were not getting any treatment before that, right? So showing that information to people to say, this is what we did. And lastly, taking that information, and what we did in Ohio Medicaid is got those stories and we show it to staff. I mean, staff was, super excited to see that. But then also take those stories to the legislature to say, put a face with, here's what it is, and then how do you start moving that forward. Lastly, I'm with Jason on value-based purchasing. We've got to move the system. A lot of the things that were said earlier, it's very, very hard to do, and there's a bunch of different ways to do it. I'm not a fan of just putting on the managed care plans. There's, Medicaid only takes up a small portion of most practices population. So are there other ways to look at that to push that forward?
So the discussion of Medicaid, so back to kind of everything that's transpired over the last year and a half. My question is, did something happen over the past year and a half in how Americans think about Medicaid? So I'd say in the run-up to the repeal debate, there was a particular flavor of news coverage around Medicaid, a particular flavor kind of more about the politics than the policy. And then, through some of your work and others, there was much more written about who Medicaid serves and a little bit more into the depths of the program. And I guess my question is, from some of the conversation earlier today, as we start to think about Medicaid buy-in, other kind of policy options in states, have we moved away from some of the conventional wisdom around Medicaid, which was that Medicaid is a political, loser in terms of, being able to defend that program? It's all about Medicare. Is there a constituency around Medicaid now, and do people feel differently about it?
Yeah, I would say no question. I think that's one of the positive outcrops of the debate over the last year and a half, is there are more people now who know about Medicaid, who understand or have a better sense of what the program is and who it serves. And I think that there were misconceptions out there that it was just a program for a bunch of young, low-income people, and people perceived that, if people just picked themselves up by their bootstraps, they'd end up, they could get a real job, and as a result of that, get access to health care. The complexity of the program, the diversity of who's served, I think a lot of that sort of came to the fore, which I think is a very positive thing. And I do think that, I think what was mentioned earlier, I think the Republican governors coming to the fore, defending the program, defending the entitlement nature of the program, defending it against really draconian cuts, I think really helped save the day, helped change the nature of the discussion. I think that's positive going forward. I do think that there's going to be some residual negative impacts from the debate. While I think those of us who've advocated for the program, I think it's a win. I think any win in a hyper-partisan environment has negative consequences to it. And I just think that it means it's more politicized, more known, better maybe appreciated by many, but more politicized now than potentially ever before. And so, because I remember there was a time during the Bush administration, back when I was the Medicaid director in Wisconsin, where there wasn't a ton of discussion around Medicaid at the national level, but states all across the country, blue, red, purple, very activist, trying to think about what they could do the best with their programs, many looking at expansions of different types, but it was sort of a little bit lower, below the political radar. It's been raised up a bit, so that does make me a little nervous for the longer term.
I think it's complex. If I told Governor Kasich this story, because I worked for him in Ohio, that if you look at the history of Medicaid, what we saw this last time, we've seen before. So in 1994, I'm in the budget office of the state of Arizona. I was working for Governor Fife Symington then. And guess what we were working on back then? It wasn't per capita caps back then, it was block grants, block granting the Medicaid program. And the state of Arizona knew that they wouldn't be able to win under a block grant, nor could they advocate for themselves. So we as a state joined with what state? But Texas. Because Texas looked like Arizona, a fast-growing state, and if you were looking at block grants, you wouldn't do too well. So we teamed with Texas, which was George Bush was the governor back then. And so I had to come forward and tell Governor Kasich, which it was one of his ideas, so that's when he was budget chairman, that he was pushing for block grants. And I was like, yes, I worked to defeat your block grant proposal, right? So things come full circle, and I worked for him. So that part to me is you're always going to see these different ways of looking at changing the Medicaid program, what's going to happen. I think that's not different there. I think you also see things differently at a federal level than you see at a state level. You saw a lot of support for the Medicaid program at a federal level for a lot of different reasons. I think at the federal level, there's a little bit sometimes better understanding of who's served in the program. At the state level, though, I don't see it that way. Again, as I said, it's complex. My advice on the Republican side, when I'm working with candidates, I always say to them, Medicaid doesn't win elections and it doesn't lose elections. Just don't talk about it. And you saw that happen in Ohio, right? You saw Republicans sweep Ohio, both the House, the Senate, all the statewide offices in the gubernatorial election, and then they elected Sherrod Brown as a senator for another term. But it didn't really come up that much when it came down when they talked to in exit polling with voters around that. So I think it's more complex than simply is there support or not for it.
So I can't sit up here being at the Leonard Davis Institute of Health Economics and not bring up the word scarcity. Economists like to talk about scarcity. And so when we think about potential trade-offs as we look to the future, where are there potential trade-offs that exist as we think about future policy directions to move toward this direction of covering all Americans? And so obviously we have to think about trade-offs in that discussion, and what might we think about? Anyone?
It's so funny because I was telling these guys that last week I was in Europe, and so I gave a speech in Sweden, and then I had meetings with folks in the National Health Service in England, and then also in Denmark. And you're talking about in countries where they're spending 9, maybe 10% of GDP on healthcare, and we're spending 18% of GDP. So the word scarcity in our context is pretty much definitely a different form of scarcity in their context. I actually think that we have a unique opportunity in American healthcare, which is that we are so amazingly inefficient. And when I say inefficient, I mean we spend a lot and don't get the outcomes that we should remotely be getting given that level of investment, that I actually think we can have our cake and eat it too. I think we can cut out inefficiency from our system. We can cut out things that shouldn't happen in our system that do and cause cost. That's why I'm a big believer in we should be really focused on avoidable hospital use, because that's a measure of human misery. Those are people going into the hospital who shouldn't be there in the first place. Example earlier, kids with asthma, whose asthma isn't managed effectively, go to the ER, go into the hospitalizations. That process repeats itself. Those are children who are suffering because the system isn't doing what it can and should do, and we are full of that stuff. And if we just focus on the right things, we can actually lower costs and improve outcomes. We don't have to get into the level of scarcity decisions like you see in those European countries. And so I think there's huge opportunities for us to expand coverage while at the same time not having to tell others that they got to wait longer or go without.
Anyone else want to tackle that one?
Well, there's a little bit of an issue, and Adam talked about this. We're getting what we pay for. Right, and so if you're a physician and you want to make a lot of money, you don't become a primary doc. You really don't become a pediatrician, which I found out the average salary for a pediatrician in Ohio is $90,000 a year. That's what they start out at their medical school. Primary care docs were at $130,000. If you're a PA, you start at $120,000, so you're only $10,000 behind a doctor. So why would you choose that versus if some of the specialties? And so you see this high cost on that side. And so some of this issue is over time, how do we change this? And as we were trying to do this in Ohio, if you could just pay for more for primary care, substantially more, not just, oh, we're going to add 2%, but if we could add 50% to it, what would that look like if you got to and you had outcomes tied to outcomes? Would you start seeing a shift towards that? Because in some cases you have a supply of physicians that you can use. It's just that they might be specialists now, and could they shift over and do some of the things? And I know they could. Now, having said that, there are some areas, just because our country is so large and so diverse in Ohio, there are some places where there are shortages. There literally are no doctors, no dentists or at all, especially in the Appalachian area. So then we've got to look at technology around that, and how do we use telemedicine more efficiently? And telemedicine not just tied to doctors that are sitting in Ohio, but wherever we have doctors that can serve those patients. So it's looking at some of our payment policies around that to make sure that those things work too.
I think what's important to know, one of the questions I got asked most often in the past year and a half is, what would be the harm to families like mine if the ACA was repealed or if Medicaid funding was cut? I think everybody wanted, an actual figure, a number. And what I always said was, the uncertainty is the harm. Our families not knowing whether we'll have care, whether we have to save up our supplies because we don't know if we're going to get another shipment next month, whether our little Timmy should get his surgery now instead of 2 years from now when the doctor recommended it, because we don't know what's going to look like. The uncertainty is the harm. It's what kept us up at night. And I think when we think as we move forward and have all these wonderful ideas, we have to think about that as well. That any change, any disruption to care, I think Chris Jennings mentioned it in the earlier panel, like we have to take that into consideration. The system's broken. I think we all agree on that. It doesn't work, but in some ways it works for us, and so we need to hold on to that. And I just want to emphasize that for in all future conversations, that the uncertainty is really what's really harmful for families like mine.
So I'm getting the cut it off sign here, but I do want to come back to one point and ask each of you to answer this if you can, which is, if we were to again project some years into the future and we were to reach a point where we were having a real bipartisan solution to healthcare at the federal level, then what is the one or two things that we would look back on that happened in the year 2019 that were done or were worked on to plant those seeds? And I'll let any of you start. It's an easy question.
First, and I think it is the movement towards value-based purchasing, and that, in moving in that direction, the things that Adam talked about. I was so glad when he took that job. I met with him one time before that, and I was concerned about the direction at that time HHS was going, and it's great to see the direction he's going in, because I think that does address one of the issues the ACA left off, which was the cost side, and how do we start building on those things so that people can get more comfortable with, hey, if we're putting more dollars into this, it's going to in the right direction, not just we're pouring more dollars into it.
I agree, although I would say that I think we're going to be in for a very interesting period, because I think that technology is advancing at an advancing rate, and it's going to create some really exciting opportunities, but also raise some very significant ethical and public policy questions that I fear a little bit our highly politicized environment is going to have to ultimately grapple with. Whether it's things like gene editing or even some of the gene therapies that are coming down the line, very, very expensive treatments, but with tremendous promise for addressing some needs that have been unmet or diseases that couldn't be effectively treated ever before. Very exciting, but will bring significant costs to the system. And I just think that I'm very bullish about the future of American healthcare overall, but that's the one thing that I worry is our political system at the national level, it's the level of dysfunction, particularly on this issue, going to not be in a position to be able to effectively grapple with this issue and really bring the country together, which I think is really going to be necessary to answer some of these difficult questions.
All right, Elena, you're going to give us the answer here.
All right, no pressure. I hope that when we look back on 2019, that two things. One, that the patients and the caregivers' voices were leading the conversations, and that the conversation has been intentionally defined on terms of what is accessible and what is affordable and what is quality health care. It has to be healthcare for all. Healthcare for some is not healthcare. And so I think we need to spend time and have that be the conversation that dictates, solutions. So when I hear the conversations in healthcare, it was always about preventive care, how to keep healthy people healthy. That's why I showed up. That's why I started speaking out. Like, well, that's not my case. That's not my daughter's case. That's why Natalie and I started showing up. What about children who need lifelong care? What about, those with chronic illnesses? What about those who are dealing, when we talked about Medicaid earlier, it's not just medical care, it's therapies, it's personal care attendants for those so they can have a good quality of life. So when we talk about healthcare for all, I want us to continue to talk about what all really means. That I'm going to just spell it out because that's what I do, but it's specifically for immigrants who need healthcare, people of color, LGBTQ people, people of different faiths, people who are living in poverty. Everybody has a different need for healthcare, and we must be sure to include all of them. When we talk about disability, it's not just physical or mobility disabilities, but we're talking about mental health, that was mentioned earlier, sensory issues, those who are living with chronic illness. I can't emphasize that enough. When I look at my daughter, she had very specific medical care that she needed, but she's also going to need lifelong care to live the quality of life that she deserves. We're talking about people who are recovering from substance abuse, who are living with trauma. So I want us to think about all in every context and be as inclusive as possible.
Well, thank you. I want to thank the two of you. And Elena, I really want to thank you for the energy and effort that you've put forward over the last year and a half on behalf of so many million Americans. So thank you for that.
Team effort.
Yeah. So your next job is you have a sheet in your folder, and at the top it says discussion guide. So your job now is to try to answer some of these questions, and there will be a note taker at your table to try to synthesize your discussion and try to lay the groundwork and really try to answer this question of the immediate actions that we think will be helpful for the future. So thank you. So nobody brought up taxes.
So if we can just finish up your final thoughts, and we are going to move to our final panel of the day. One agenda update. Unfortunately, Senator Schatz has been called back to the Senate and is not going to be able to join us for the fireside chat, but don't fret. We have a fantastic panel with three of our board members. Our board chair, Andy Slavitt, will hear from again, and he will be having an engaging discussion with Christy Canigallo and Senator Dave Durenberger. And I'm sure Andy will have fuller introductions for them as we kick off our final panel.
Am I sitting here?
Sit there, yeah, why not?
All right. Okay. Who's got the best shoes up here?
I mean, Andy, really,
who's gonna vote for Dave?
Your shoe game.
He always wears the same shoes. Good guy.
Me too, guys.
Well, my
every
socks
day.
are fancy.
Every
You're
day.
lucky. Yeah, you who votes are. for my shoes? Yeah.
All right, who votes for Christie's shoes? A lot of people not voting.
How about boring?
Predictable.
Predictable. Yeah.
We were trying to think about a way to close the day, and I think we need to think about the day as a launch point for all of the people in this room who've come together and given some great ideas. And I think what we have an opportunity to do, as I introduce our two panelists, is I am sitting here with two people that have lived through the most recent major health reform efforts that we've undertaken as our country. Dave Durenberger, Senator from Minnesota. We've had a couple Minnesota people up here today. He's a Republican senator who's written a great book called When Republicans Were Progressives.
Right.
And I encourage people to look at it. And even buy it if you so desire. It's a great book. But Dave's has been a health policy leader since his time in the Senate and subsequently, focusing on policy ideas that work. He's been very outspoken and I think lived through the Hillary care and several iterations attempts at federal health reform. People may remember Bennett Wyden and other things. And he's a consigliere to me and a great friend.
Okay.
Christy Canigallo, who's on his right, was pretty much over the years ending in 2016, she was pretty much everybody in Washington's boss. Christy served in the White House as the deputy chief of staff, but for everybody who knows Christy, knows Washington, knows how things work, Christy was the person that oversaw really the operations of government policy from the development to the execution, and where Christy was just an incredible mentor and partner to the implementation. How do things work? Are they working? Et cetera. And so oversaw the ACA implementation, and really from the time it started getting turned around all the way through the end of the administration, and certainly has tremendous lessons from that process and that policy. So the two of them I think, can give us a really unique lens as we think about going forward, without refighting the battles of the past. What are the things we should be taking away? So that's where I think we're going to start the conversation. And I'm going to start with a really meaty question, which is the role of lobbyists, the role of special interests. Mm-hmm. It seems like, if one were observing, would say that this time around when we were looking at the repeal of the ACA, that there were a lot of closed-door sessions. People were not able to see what was going on in the text of the bills, except the way we started to learn about them was lobbyists would start to release these talking points. Mm-hmm. True with the ACA as well, that the lobbyists were a big part of the deal cutting. So I wonder if you can reflect, maybe starting with you, Dave, how do you see
what's the appropriate level of influence? What's too much? And how do we get it right? How do we, if it is too much, how do we make sure we do that better?
First, with regard to the talking points issue, which is today, I want to compare it with yesterday. If you're getting talking points from lobbyists, that means the committee structure is not working. I mean, because the committees in the Senate in particular, and the committees in the House as well, during my period of time from 78 until the end of 94, the committees where all the action happened. And all the action happened in the open. I mean, the only time we'd go back into a closed door is when Bob Packwood couldn't get a tax bill off the ground, and we had to figure out how to do a tax bill. So, but other than that, it was an open book. The function of the lobbyist was to help us. In our day, literally, I could give you examples of how I knew somebody who lobbied in a certain industry that was ahead of the curve, and I'd ask them, go find out why and translate that into this particular need that we have. In our day, we did that in environmental health. We did it in a lot of areas. We'd find somebody, who represented the profession or the part of the system that we were going to impact, who could find a way in which to be helpful in the old-fashioned sense of the word, which was make it better policy, not to make it simply favorable to their own position.
So you're pointing out something that I think is not a lot of people really completely understand, which is how much senators and members hunger for education.
Yes.
They want to understand these bills. They see a wide array of issues.
Right.
All of us care deeply about maybe one or two things. You've got to be responsible for everything. And so the lobbyists serve that purpose. Yet it feels like that the tip-over point becomes when it moves from education to the fact that there seems to be veto power at work, or in the case of Hillary Care, they're running ads against Hillary Care at the same time they're talking to you. So how do you manage that, really, with the goal to be we want to hear from people who are affected by the policy as we policymakers make those decisions?
Because you have to make it very clear to them. The leadership has to make it clear to them. Whether it's the Democratic leadership, the House leadership, or both, usually, or it might be the conservative, liberal, or progressive side of the Republicans, or the Democrats, as the case may be, has to make it very clear that who's going to be making the ultimate decision, and on what basis are they expected to make those decisions, because a whole lot of people, 1/3 this year, are going to be up for re-election, or whatever the case may be, even put a political point on it.
Right.
So it becomes a leadership. It becomes a leadership issue, and as well as, what happens in the relationships between the Democrat and the Republican at a level in which you're going to have to live with the product that comes out of this.
I mean, I think the other element of it is, to what degree is there the apparatus to leverage the everyday American's voice? Is it consumer groups? Is it patient groups? And is that apparatus functioning effectively? What we saw last year was new apparatuses, some in this room, some of the infrastructure, groups like Indivisible, folks who might not have previously thought to make their voice heard through an existing structure. We saw new structures. So it's ensuring that, in addition to kind of the traditional corporate special interests, whatever words you want to use to describe the traditional structures, that there are new structures that are able to give voice to the everyday, Americans' experience.
Is it beat them at their own game? I mean, I look at Little Lobbyists, which Elena founded, and some of the work that Natalie and others have done. Is it that you just have to accept the fact that this is an influence game, and we've got to fight it just as well as they do?
Yes.
Yes.
I mean, my biggest lesson of, I did not work on developing the Affordable Care Act and passing the Affordable Care Act, but my biggest lessons from times working with Hill is give them something to be for. Folks, members, they see a problem, they want to solve it. You've got to give them something to be for, because a plan beats no plan anytime. And so you've got to be engaged in that debate, otherwise the terms are going to be set for you.
But it was also 2009 versus
Yeah.
1950, or excuse me, 1992, or excuse me, 1993, 94, 95, because there were always 27 senators meeting in Chafee's Hideaway, because we had problems with Bill Clinton's acceptance of Hillary Clinton's obstinacy, if you would, on one hand, and on the other hand, Newt Gingrich and Phil Gramm and all the rest of those guys didn't want anything to happen on the Obama watch. But in between, there was still this bipartisan effort, which kept everybody on it.
Okay. But let's just to put a fine point on it, well, the influence goes through the process, but then at the end of the day, are the lobbyists part of the deal cutting? And really kind of put a fine point on the ACA, what you observe now is the deals that were actually cut, the lobbyists, of course, then feel, well, let's just wait for the next Congress so we can go back and retrade those. Oh, we've agreed to pay an insurer tax, or we've agreed to pay a medical device tax, but really not really. So is there something structurally that allows people with the extra influence to be at the table, and is there anything that can be done about that?
I mean, I'd say
If you
yes.
have a good answer here,
No,
yeah.
no. I mean, I say yes, of course, because again, using my experience as an example, if I end up knowing what I'm talking about, and so does my counterpart on the Democratic side, and they've made commitments to other Democrats, and they've made commitments to other Republicans, on which they're going to have to go home, even though they don't understand anything about the issue. They got to go home and and defend it and so forth. Of course, you're going to keep. You have to be an honest system, and so anybody who is a lobbyist who expects that they are going to have some special advantage in a system like that will not make it, because there's somebody on that committee, usually the chair or the author of the bill or one of the principal co-authors of the bill, that isn't going to deal with that, some special notice.
I think the answer is it's transparency in education.
Yeah.
It's trying to introduce as much transparency as possible into the system, and trying to introduce as much education, not only of members, but of their constituents into the system, so that they can be active participants in the democratic process of governing.
Yep.
And when that system is working, when that system is transparent, when folks are well educated to be able to engage, then we were able to produce the best outcomes.
So are we really having a conversation right now about Citizens United and gerrymandering and redistricting? Yeah. Are we really having a conversation about how much members feel like they are today at risk in a general election versus either a primary or they've got to raise $15 million to run the race, and they raise that all out of district? Is healthcare just not to the most immediate urgent need? Is it really the urgent need somehow reforming how that works?
I think right now healthcare in particular is an incentive for people at the state and local level to say enough already. And I'm reflecting largely only Minnesota when I say this, because that's where my experience is. But if you go into any local community, it's like enough already. I want ranked choice voting, or I want change the primary, the role of the primary, and things like that. This conversation is hot. Not just because we had an election, right, but because we've had a series of elections, in which it's pretty clear who the winners end up being in that election, and the public is not happy.
So is it true that if you care about healthcare, you should be focused on election reforms?
Yes, absolutely.
Yes.
I mean, healthcare is a manifestation of our electoral reform challenges.
Got it.
I absolutely agree.
Got it. Let me go to some widely held views about what can get done at a policy level. The view that I think emerged out of Hillary Care experience was what I would describe as people put the me before the we. In other words, when you poll people and ask them how they feel about other people having access to healthcare and health insurance, the answer is, sure, of course, that sounds great. But when you pair that with the idea that you might lose something, you as an individual might have to sacrifice something for that to happen, even if that sacrifice is uncertainty, that you might not be able to keep your doctor or your insurance plan, or you're going to go into some pool of uncertainty that will never fly. and that prevents things from getting done. Is that true?
It wasn't true in 94. It wasn't true in 94. I mean, in 1994, the public was ready for something, but they weren't ready for nothing. And that's really what was going on. And that's why the small group of Republicans who engineered this change, took advantage of Hillary's, I'll call it stubbornness, if you will, but she got wedded to these 500 people who'd helped her, make this commitment until it was too late. And even though we had put this process together and then we put the actual piece of legislation together, we weren't able to get the kind of consensus that George Mitchell could count on.
So was her mistake process or was it policy?
Well, it was a policy process. I mean, it was. In the
Hillary care.
Yeah, it was a process.
It was
a process issue. Oh yes.
And so, what would you do differently? Have those lessons been learned entirely, or do they need to be? Can you remind us what they are?
Yeah,
the process lessons.
The first lesson is the people who make the policy have to understand the consequences of the policy of what they're doing. It's just like we just spent 45 minutes at each table talking about these kinds of things. That doesn't take place up there anymore.
Right.
But it's critical, and it's a critical issue to put in front of leadership on both sides of the aisle and to put in front of your congressperson or senator or whatever ASAP. And there's a neat thing. I don't want to get the detail, but one of the things that's happened in this last election is you can't get by just on attacking somebody anymore. You have to justify what you did in the odd-numbered year, before you became a candidate. And it isn't just healthcare, but healthcare is an important part of that.
Right.
I mean, I think to apply it to the ACA context, I think in the fall of 2013, in addition to extrapolating that lesson, policymakers and those who are developing the policy also need to have operationally excellent counterparts to ensure that you are able to implement your policy and it lives beyond the text of the bill. I think we also could have done a better job focusing on, you talked about the losers. Not everyone is going to benefit equally, and who will be harmed, and not be afraid to have that discussion, not be afraid to have that discussion internally, not be afraid to have that conversation with the American people, because it was true with the ACA that the vast majority of Americans either were not affected or benefited. But it was also true that there was a small number, a small percentage of Americans that did see choice reduced, that did see costs go up. And I think not being willing to engage in that conversation and acknowledge that, I think, did us a real disservice. Obviously, that came back around in terms of, if you like your plan, you can keep it and things like that. But I think as policymakers, being willing to table the negatives and the losers, and not be afraid to have that conversation and have that conversation in public, even though it may seem like that is a risk or that introduces vulnerability, but it's a much bigger vulnerability not to engage in a transparent, comprehensive way at the front end.
Right. So let's go to that comment, because I think, at least I feel like I understood what President Obama was saying, which is for the 90% of people that are covered, the ACA is not going to touch your doctor, your health plan. And so yet a year later, when your health plan Aetna decides they're not going to offer themselves in Southern Ohio to your employer, some people will rope that back. But there was this need that he was speaking to say, we've learned this lesson. What's going to happen for other people isn't necessarily going to impact you. But there was something else you said, which I think is fascinating, which is that you take a look at the ACA or any complex legislation, and let's say success is it works 80% and 20% of it needs to be fixed. Would we say that's a pretty good result?
Mm-hmm.
But what broke with the ACA wasn't that there was 20%, in my view.
Yeah.
It was that we had no will as a country to address the 20%. That there was a point in time, and I assume this happened between your time and your time, where if there was 80% that worked, both parties could get around the table and say, see these things that didn't work, let's put on some follow-on legislation to pass them. And that with the ACA, that wasn't possible. So that feels like a cultural change that happened that meant that you pretty much have to be perfect or every mistake's going to get taken advantage of. What's the deal? How do we fix that?
If David Broder were alive today, he could tell you what he told him. My wife and I got 40 of the 60 people that were most intimately involved in Hillary Care, to come out to Minnesota in April. It was April of 2008. Before it was Obama and Clinton and, John McCain. And we spent a weekend, which David launched us into. And the first thing he started saying is, don't try to write a health plan here to help those people, even off of your what you consider your mistakes the last time. He said, do politics. Anticipate the politics of this. And some of those are partisan politics, and some of those are lobbying politics, and some of them are, the way large, powerful groups like employer groups and so forth might feel about it. And we went out of there on Sunday afternoon. I remember Sheila Burke just moderated this discussion from all of us with something we call the 10 Commandments. And they were the 10 Commandments of how to design a political process. And President Obama I know he started with number 1, which was getting 150 of the representatives of the 150 stakeholders in the room on March 4th of 2009, saying, going through what he proposed, and at the end of the day, I know who it was, the woman who ran the American Association of Health Plans, who came out, made the statement on behalf of 150 stakeholders, right? Mm-hmm. Saying, we're all willing to give up something or to bring something new to the policy table if, in fact, this kind of bill passes. So he started down that small p political path, and it was something else that derailed him later on.
What I've witnessed with lobbyists and influence is that if you can divide Congress, then is it 10 minutes until questions or 10 minutes till we're done? 10 minutes. Till questions. Okay. Thank you. And you do an awesome job.
All day long, she's doing an awesome job.
And you have no idea what a health policy expert this woman is.
I know. I do.
You do. That's true. You're in Minnesota.
She's good. Yeah.
But when you can pick people apart, then I think it's easier for lobbyists. So I guess my question is: will there ever be a gang of 8 again, or a gang of 14 in healthcare? Will there ever be enough of an ability to for there to be some strength in numbers for some people who are committed to getting something done? We had at one point Ron Wyden, who was going to come by but had to stay in Oregon to talk about this, and Bennett from Utah, who were committed that they were going to get something done. We have Lamar Alexander and Patty Murray, who, for anybody who knows the two of them, there's a very serious-minded people who are policy-minded people who want to get something done. But it feels like today Murray and Alexander are an exception. And I'm wondering, how do we build back a culture? I'm asking a culture question, a culture where leaders can stand up and say, we have some first principles that we are going to drive toward.
I absolutely think we'll see that again. It may not feel like it right now, sitting in Washington, D.C. at the height of hyper-partisanship. But for those of you who are working in the States, as I am exposed to the things that are happening at the state and local level, bipartisanship is happening. It's just not super sexy to talk about. Although it actually is quite sexy to talk about, because folks in your states and your districts, they actually want bipartisanship. They want folks to put politics aside. And so I think, notwithstanding what's happening right now in our country that makes it feel very hard for Patty Murray and Lamar Alexander to sit down and pass something, an ACA fix-it bill, if you will, I am confident that kind of the worm will turn on that in a positive direction. And it comes from identifying at a local level things that work, partnering with folks of kind of different stripes just to get stuff done. And good work builds on good work, and folks want to be a part of that. I'm not so idealistic to believe that healthcare won't always be one of those uniquely political issues, but I do believe that that we can kind of push back on the torrent of partisanship by showing people the benefit in their day-to-day lives and by coming together. I'm hopeful.
The other key to this is the United States Senate. And the first thing I learned when I picked Finance Committee, not even knowing what it was because I had been running for governor and then got elected in the Senate, was Russell Long. And Russell Long taught me why the founders chose to propose and to pass in the part of the Constitution a Senate that had 2 members from every state. Because he added to that, when every state is heard from, you get good national energy policy, and his was an energy state, mine was an energy consuming state, or you get good tax policy, whatever the case may be. And so for those who advocate, making the Senate a popular, if you will, source of being productive, don't do it. I mean, get back to what the Senate was, and the way you get back to that, of course, is state by state by state by state, just like we're trying to do here.
Do you think, this is both of you, do you think that the Senate should commit to not passing major health reform legislation without 60 votes? In other words, not using the reconciliation process that was used? What do you think? Not knowing who's going to be in charge?
Yeah. Yes.
You think so?
Yes, I would.
Yes.
You
think they should commit to that?
Yep.
Yeah. What about people in this room? Who thinks they should? That the Senate should commit to that? Who thinks they should not? It's when you're in the minority and you're majority, things look a little bit different.
Yes, exactly.
But the ACA does exist now, and it's still the law of the land. I don't know, but I feel yes today. But I mean, I think if there's a lesson from, it's like
now we're negotiating.
Cut it off now. I don't know if there's a lesson from the ACA repeal debate. If there's a lesson from kind of healthcare being a dominant issue in the midterms, again, it's like that there's more that divides us, or the more that Freudian slip there, more that unifies us than divides us. And so if you take where we are as a starting point and say that the majority of people are for this, and then you build on top of it, I appreciate we wouldn't got the ACA done, but we got it now, and so let's build on that.
I think if we did it right now, I don't know whether I'm changing my mind or not, but it sure sounds like it. I mean, if you're talking about now and in the foreseeable future, I'd have to say 60, at this stage. But we didn't need to have that kind of rule in the old days, except for budget matters.
Yep. Talk about the steps in the road towards getting some major policy passed. One of them is the CBO. And the CBO is something, I've heard the same person as everyone has heap praise on the CBO when they like the answer, and then heap scorn on the CBO when they don't like the answer.
You've never done that, Nancy, of course.
I was going to say, fortunately, I'm intellectually consistent 100% of the time. You don't have to laugh so hard. But I think one of the barriers, we were talking over at our table about how hard it is to rapidly implement good ideas. And we were talking with Darren, who ran the 10 Care program for a long time, about just even getting a simple waiver. If something works, you've got to wait 3 years to figure out if it worked, then you've got to do another one. You've got to go through a whole set of processes. Every state thinks they're different, a whole new set of circumstances. CMMI, to a degree, is intended to help that. But then when we come up to federal policymaking, presuming that it's still in fashion to pay for things, which it may not be any longer, but presuming it's still in fashion to pay for things and be budget neutral, or presuming that that's a goal, you've got to go through the CBO, which I think millions of Americans had never heard of, and all of a sudden, with the repeal debate, heard of it. What are some of the things that you think of that can be done now to gather evidence, to put things together that when the time comes can give the CBO something to work with? Is that a place to focus?
Only to the degree that in advance, let me just say, I'm a great believer in CBO. I mean, I've seen it. It's a needed discipline. And at the time when you really want your thing just so badly, they want to get it over the finish line, somebody needs to say, you got to be honest about the consequence of this. And and so I'm a great believer in it. But I heard something today from the former governor of Kentucky that I really enjoyed, which was when he said, what I did once I made the decision was I called Price Waterhouse or whatever it was, and I had them come out and do this. And then after the fact, a year later, I got Deloitte, to do this. And I thought, oh my God, that guy should still be the governor. Or maybe he should run for the Senate. Maybe, Mitch McConnell's place in the Senate or something like that.
What do you think? Anybody? Steve?
I mean, I remember for many days between October 1st, 2013 and the end of April, or middle of April 2018, hating the CBO for that 7 million. But good Lord, once we got that 8 million people enrolled, I loved the CBO because we exceeded expectations. So I actually think if there, I think not just the CBO, but I grew up as a career Department of Defense civilian, and thinking about the entities in our government who are doing nonpartisan, the nonpartisan work of the people that folks may not realize even exist, but actually hold so much power and have such responsibility to be pursuing their missions in a responsible, apolitical way. I think anything that we can do to be reinforcing at a time when, again, to previous discussion around hyperpartisanship in Washington, at a time when we can be investing in and supporting those groups, be it CBO, be it our career staff at HHS, I think we should be doing that as folks who are on the outside. As someone who has lived it on the inside, it's easy to be a punching bag, but really, those entities in the U.S. government are some of the most important, enduring, and responsible actors who will ensure consistency and appropriate analysis over time. So we should be looking for any way we can to support.
1 point for the deep state.
Hey.
I love the deep state. I want to get that T-shirt.
I had the auspicious. I think I'm perhaps one of the only people. I worked in the White House under President Bush and stayed under President Obama, and then was one of President Obama's senior advisors. My own learned experience is that there are outstanding people in government who are given a bad rap, and even the talk of the deep state gives them a bad rap because they're just trying to do their jobs. And we all should take a moment to think when we're talking about government workers, it's a bunch of great people who do thankless things.
Amen. Amen. Great point. Okay. So we have some time for questions, and where do you want to go? We've got mic runners. Molly Coy, we've got a mic behind you.
Trouble with my audio before. So do you think that, talking about United States of Care, what potential do you think there is that by going state by state that we can build more basis for consensus and bipartisanship? It seems to me that maybe one tactic is not going head on in Congress and the Senate right now, but to building a trust level with some of the major players. We heard the speaker from Pacific Business Group on health. When we can get the business community really involved in Medicaid expansion, supporting the business cases you were talking about, Governor, is this a strategy that you think has real potential?
So this is the United States of Care flanking strategy. What do we think?
The Schlieffen Plan.
You want to go first?
I think it makes all the sense. I kind of joked, but I was studied military history as I in school and whatnot, and I think at a time when there's such resistance at the federal level, and also such low potential for change, right? I don't know what Congress is going to get done in the next 2 years. Why wouldn't we focus? Why wouldn't we focus on the states where there is high potential for positive positive impact, and where we can try some stuff? Actually, I think being in a position to take a little bit of risk in kind of lower, lower risk markets, I think is smart, because now is the time for us to be trying a bunch of stuff, seeing what works, and then seeing how we can scale it. So I'm a big believer of kind of the localized strategy.
Yeah, and having the benefit of spending 2 days in Minnesota with Andy and with other staff and watching Minnesota represented by 6 different groups of people that are core involved in this issue, Molly, react both to the goals and objectives and to the way that Andy in particular handled their questions and the response to it and so forth. I am persuaded that that's the only place to start. And again, I listened to Steve this morning talk about local government and change and state government and change and the pressure. That's where the pressure is, and that's true all over the country, and that's where we can distinguish, to some degree you can distinguish Kentucky from Minnesota. But when you get down to the local level, you talk about the mayors and the city council members and the school board members and all that sort of stuff. Everybody there is beset with the same kind of sense of their particular obligation and how they ought to discharge it. It has nothing to do with all these other things. So I loved watching this process, if you will, at work. And yes, it's steered by a master, but the confidence that it builds up as we sit there for 2 hours in each of these different sessions, each with a very different group of people, was really amazing.
Yeah, I want to go to Emma, but behind you we've got a legislator from Minnesota, chairs the Commerce Committee, and the fact that we have taken a state that's had a pretty acrimonious couple of years, and month after month we're getting Republican and Democratic leaders in the room talking only about policy and ideas and working together. I just think it's been a remarkable experience. I want to thank you for that. Emma Sando.
Hi, I'm Sando from Harvard. We used to live in a world where the Congress created demonstrations, and now we're very much in a world where 1115 waivers and 1332 waivers and SIMMI has sort of moved that center of demonstration support from Congress to the administration. I don't know if that is because of changes in the law, the partisanship in Congress or CBO or whatnot, but as we facilitate state being the laboratories, they need a federal champion. And in the future, going forward, should that be Congress? Should that be the administration, or a combination thereof? Like, what is the right way to do this?
I think the executive branch is the right home for it. I think there is you have in CMS, you have the resident expertise to help folks think through those demonstrations. So I think the executive branch is the right place long term.
Good. Other people? Questions? I will ask a question while you consider whether you have a question, which is oftentimes figuring out where to start and when something kicks off. I think what we're used to seeing is 2 presidential candidates, they kind of hone their policy positions, they run on a specific policy, and we tend to think as a country that whoever wins, that's certainly going to influence what could get signed, but that kicks off a policy process. The president decides, along with the White House, some version of, okay, when do we start? This is a good first-year priority. What should this be? Should we put infrastructure first? Should we put this first? Then you could start either in the White House with a bunch of work. You can have Congress start. It can start in committees. It can start with some leaders. It can start with a big coalition. There's lots of different ways to do it. You were close, obviously, to the Obama White House processes. You lived through several of the other ones. Some things that worked, some things that didn't. Is there a best way? Is there a best way to start the process where, and I'll define best as maximum transparency, maximum likelihood of getting something done, maximum ability to get good ideas in the process, but also one where, you know, the sort of pettiness of this wasn't my idea, this was yours, doesn't get in the way.
We did that just on my watch, between January of 1979 and early 1993. That's what we did. That's the way we operated.
How?
Well, there's a process in which the president will initiate. Jimmy Carter initiates this particular proposal to do the New Jersey version of budgeting hospitals, and I think he had probably he did include, had a separate vote on doctors as well, doing national budgets, annual budgets. And the response to that, I'm a brand new guy at the time, I'm trying to figure out how things work, to say nothing of the subject matter, but the reality was, it was a combination of Republicans and Democrats that shot him down, including Dick Gephardt, who was then the ranking Democrat on the congressional side. That was the beginning. And then we get to the Reagan administration, and he announces that it's going to be free markets and all the rest of this sort of thing. And he appoints Dick Schweiker as his HHS secretary, and Dick was a senator from Pennsylvania, and he understands how the process works. And so in the Finance Committee and in HELP and in the comparable committees over in the House, the work begins to work with the administration to try to figure out what do we do by the time we get the first opportunity to get to the floor, which will be in 1982, when we got to do something on the Budget Act. And so up comes whatever it was, OBRA 82 or COBRA 82 or something like that. And on it, we had a series of fairly major pieces of legislation, including what is now being called Medicare Advantage or Medicare Cost or something like that, which actually surfaced in 1985. But a variety of these things happened because we set a time frame for it. There was an opportunity that you could predict ahead of time, and at the committee level, in the subcommittee, and then in the full committee, there was a commitment to use, in this case, the budget resolution as the vehicle for meeting both the budget target, that's why this CBO thing we had here earlier was important, and the new policy change target as well.
Got it. So, Christy, there's very few people that I know that are as good at figuring out how to get something done in Washington with all of these very complex pieces. Is there a best way?
I mean, I think the best way is, there are principles, right? Be transparent, be inclusive, and be ready to go. Like, have done your homework, be transparent, be clear about what you're trying to achieve, be inclusive, engage in as broad a debate as you possibly can, knowing that you don't have the, you don't have the best ideas necessarily nailed down, and then be ready to go, because you never know when your moment is going to hit. And even though you might not be priority A1 on day one, if 60 days in suddenly priority A1 is stalled, having that kind of suite of solutions is I think behooves everyone. So in some ways it's really easy to say. It's much harder to do in terms of being transparent, being clear about what your objectives are, being really clear about what you're trying to solve for, getting folks around the table, and then being in a position to deploy your solutions.
Got it. Okay, I'm going to ask one final question, and it's a really short answer, but you got to try to be honest, not give the positive answer just because it's easy. Do you think there's a policy that 70 people in the Senate, 60 to 70 people in the Senate could vote for over, let's call it the next, 5, 7, 8 years, that both parties could land on 60 to 70 votes, unless one party has 60 to 70 votes, which is also possible, that would provide everybody in this country access to affordable health care?
If this room does its job, there will be
a policy, he said.
A policy?
Yeah.
Yeah.
And those lobbyists that were the first question, those guys still exist too? Right? I mean, there's got to be something. There's got to be something in the drug space. Lobbyists aside.
Okay.
Yeah. Well, I have my personal favorite, And, yeah, and that's having made the decision to pass Medicare and Medicaid and pay the price of using their insurance companies to get it paid for, we broke this system into pieces that are now X trillions of dollars a year and all the rest of that sort of thing. So we ought to get back to the original, which is to recognize the value of health that is both the patient or the consumer has and the value of health that a health organization may also have. And the way to do that is to allow people to buy multi-year memberships in a health company.
So
you name it, Mayo Health in my case, or whatever it is, one of the old HMOs or something, but it's a health company. And it's one of the current semi-integrated systems in your state and so forth, you know, that can sell you a membership on an annual basis, but they can sell you a multi-year membership, which means that the stake that you have in it, as well as the stake that they have in it, is the same.
Got it. Okay.
That's my favorite.
We are not done. We have two more quick ones. The Honorable Governor Beshear.
Well, there's one word that hasn't been mentioned today that I think describes why we're where we are and why this United States of Care is so important, and that word is leadership. Right now, in the area of health care, we don't have leadership on the federal level. We don't have it out of the executive branch. We don't have it in Congress. And that's why it's so important that we get into these states and start developing various ideas and innovations, because there's a void right now. You know, we have decided to define our jobs here in Washington as winning and losing.
Right.
It's not whether we did the right thing or wrong thing, it's just whether I beat you or not. And that's the way the system is working right now. And I don't see us getting anywhere while we've got that kind of situation going. But we can go a long way on the local level and on the state level to start building that momentum. And if you look at what happened in these midterms and the fact that for the first time in my memory, healthcare was at the top of everybody's list in terms of why they voted and what was most important to them, that momentum is building out there. And I think that we've got to be ready to take advantage of the opportunity when it surfaces.
That's a great point. Yeah. Do you have comments on that?
Agree. I mean, just yes.
You wrapped this in the context of leadership, but you also said something else that I think is important for us all to think about, which is being opportunistic. We don't know when the environment will change until it changes.
Right.
And we have to be ready for it. And if you look back at the history of legislation passing, and you look at, say, for example, you know, we pay for anybody with kidney disease to get health care because we had a problem. We get Ryan White because we had the advent of HIV. If we have a cure for leukemia tomorrow, the American public's in a damn well demand that we figure out how to pay for it for everybody that's gotten it. So I think we also need to, in addition to being planful, we need to figure out how to take advantage of opportunities and be there at that right point in time.
And leadership, I think, you know, traditionally when folks think about leadership, they think about something other, right? This, you know, someone else who's, you know, leadership in this moment, you know, is distributed leadership. It's everybody in this room looking for ways to be leading in your communities and to be leading with solutions and to be leading with ideas. And us all, the collective action, you know, we don't have a collective action problem, we have a collective action opportunity, I think, in the healthcare space.
Great point. They're going to turn our mics off, but we have Jason Helgerson, please.
I'm generally a very optimistic person. I think my one big, and I mentioned it on the panel, and I'm wondering what your thoughts are about this, is that technology in healthcare is advancing at rapid rates, whether it's artificial intelligence, machine learning, gene therapy, gene editing, all this technology is coming, and it's not that far away before it's really going to start changing the nature of how the healthcare system operates. It's going to change fundamentally the roles of different types of providers. The role of the physician, the role of the hospital. These things are going to be fundamentally changed, and my fear, if I'm going to put my pessimist hat on, is that our fractured political system won't be able to respond to this fast-changing environment fast enough, and that what is already a challenging system already potentially gets worse because our political system can't respond to the changing technology.
So let's see if we can rapidly react, and then.
So as someone who currently works at Google, look, I worry about this a lot when I think about kind of regulation and our statutory regime shooting behind the target in the tech space, and that is healthcare related. That's on other stuff as well. So I share the concern. I think the onus is on all of us to be beginning to not have a tech conversation and a healthcare conversation. These aren't different things. Like, technology is not this different thing. Technology is integrated into how we all live our lives. And so how can we be bringing technologists to the table, to every table where we're having these conversations? Because otherwise we're going to have exactly that problem that you suggest. But from a regulatory regime perspective, it's something in the Obama administration we didn't get right. And I worry that there's going to be a kind of a more of a fracturing in terms of the gulf between how regulations keep up with kind of technologically innovative and dynamic industries, and we've got to fix this problem. I share your concern.
So just a question of you, which is explain the monopoly of Epic and Cerner and the inability for me to communicate with any of my, any provider in my community who happens to use my chart, which is an Epic deal, but they don't communicate. I mean, you all know the issue.
Yeah.
That are we ready? Well, we can get taken advantage of too.
I'm going to take Jason's question as an opportunity to close, to say thanks to the panel and for your amazing service. And I think from your examples, and it's something that Governor Beshear said is the way I think I would address your question, is we need to look at every threat as an opportunity. So what is there in the fact that things are changing? Because it may be more of a threat if nothing changed. Because our industries in healthcare are so consolidated, people are making so much money that there's very little reason for people to want to change. But things that throw a loop, like technology or other things, I think we all need to look at as opportunities to leverage to either never waste a crisis, or if it's in fact something that moves the ball forward, use that as a way to change the equation. So thanks very much.
Thank you, Andy and Senator Durenberger and Christy, for that timely and wide-ranging conversation. And I want to thank all of our speakers and panelists today. I think it was a fantastic program that hopefully got everyone thinking about the issues in a different way and from a different perspective. I know I now have the pleasure of being the last speaker, but standing between all of you and the reception. So I will be brief, but I do want to take a few moments to wrap up all that we've heard today, and more importantly, how it will impact the next phase of our work at United States of Care. We launched United States of Care earlier this year around a simple but ambitious mission that you've heard a lot about today, that everyone in this country should have access to affordable health care. At the core of it, we believe people are more aligned around that end goal than current politics would have us believe. And we embarked on this effort to make sure that people and patients are and remain at the center of this work. The system needs to work better for everyone. Sick and healthy, old and young, rural and urban, lower, middle, upper income, people of all backgrounds and all cultures. Sickness doesn't spare any of us, so we need to all work together on forging a healthcare system that focuses on people and patients, and not on the political divisions that so often sidetrack the conversation from that focus. One of the key objectives of United States of Care is serving as a catalyst and an incubator for new ideas, and supporting innovative policy approaches that can get at the core of those needs of what people feel and experience. Not an easy mandate when you're talking about a problem that's been the focus of reform efforts at the national and state levels for decades, but it's also one of the most exciting elements of our work and our philosophy, that we get to think about what's next, to forge a proactive vision for what could work better for everyone. And most importantly, that we can bring people together from across the spectrum and from all sectors, as we see here in the room today, to try and make it happen. Today has been a great day, and I want to just take a moment to thank some of the many people who make United States of Care and this convening possible. We've heard from some of our board members throughout the course of the day. We are really grateful for their leadership in guiding a new organization through this critical early period. Andy Slavitt, our board chair and founder, provides vision and boundless energy to drive this organization forward. We heard from Senator Durenberger and Christy Canigallo. I also want to thank Senator Frist, Governor Douglas, Governor Beshear, and Rhonda Meadows, and really their visionary leadership is just critical to us being able to do our work. I also want to acknowledge a group of individuals who generously offered their time to assist in the planning of today's event. Elena Hung, Molly Coy, John McCarthy, Ian Morrison, Ben Miller, and the team of the Leonard Davis Institute at Penn. Their guidance was invaluable in shaping the speaking program and the overall experience of this convening. I also want to thank our incredible Founders Council, many of you in the room today representing a great and diverse set of perspectives that inform our work, from policy leaders to hospital leaders, entrepreneurs, former elected and appointed officials. This group is really our secret weapon, allowing us to punch above our weight class and access some of the top expertise in the nation in support of our work. We also have many donors here with us, including some of our very earliest supporters who provided seed money to get us off the ground. And I'm sincere when I say we could not do this work without you. So thank you for putting your trust and investment into a new organization. We want to continue earning that trust all the time. Today's been a great day, and I just want to make sure that we are all leaving as inspired as I am, and that when we reconvene a year from now, that we aren't just repeating the same conversation without reflecting new progress and new accomplishments. That will mean we'll have wasted a year. I want to make sure we each go back to our respective networks and communities inspired to take action. To that end, if you're already engaging with us on a regular basis, thank you. If you aren't, or if you're new to United States of Care, if you're tuning in by live stream, if you want to know how to get involved, I have an ask for you. Reach out. You've heard today from many of our senior leadership during the sessions. Find one of us at the reception. I'm going to be available. I'm always available by email, and many of you know how to find me, but reach out and ask how you can plug into our work. We need to use your voices, your networks, and your passion in moving the ball forward. Can you write an op-ed in support of our mission? Do you have policy expertise that could support our state partnerships? Do you have a public opinion background that can help us keep our focus on where people are? Do you have stakeholders or interested people in your network, or interested donors that we should connect with? Are there innovative policy ideas that are incubating that we should know about? Let us know. And please spread the word to 5 contacts and ask them to follow us on Twitter, join our email list, and stay updated. We want to hear from you because we are a small but mighty team, and it will take all of us together to fulfill this ambitious mission. And on that note, I want to finally recognize the United States of Care staff and interns. Can all the staff stand or wave your hands? This is a small but mighty team, and it does the work of a much bigger group. And they operate with a level of enthusiasm, focus, and excellence befitting our mission. You heard from many of our leadership team today who are fantastic, but I want to make sure we're recognizing everyone. This event was a team effort across the board, and the unglamorous work of stuffing tote bags and organizing table assignments is incredibly valued. I especially want to recognize Meg Garrett-Reed, who was the architect of this whole day. From straight over there, from pushing us to think about the big picture themes to making sure every detail was covered. I'm really proud to lead this organization every day, but especially on a day like today. I can't say it enough, but I'll say it one more time. Thank you to all of you for being part of United States of Care and for standing up together to say that we can do better. One quick housekeeping note. In your packets, you have evaluation forms. Please take 5 minutes before adjourning downstairs to the reception to fill that out. You can leave it at your table. We really want to hear your feedback. We want to make sure that we are thinking about all the right aspects for the next time that we convene this group. You can leave it at your table or hand it to a staff member, and we'll make sure that that gets back to the team. Thank you again, and please join us for a drink downstairs.